Yeah, no, I can start.
Huh.
Can you open? Hi,
Now
Dr.
that is,
Pradeep. Can you hear me?
yes, Bharti, we can hear you. Is our ICOG chair here?
Madam is joining, madam.
Yeah. Chitra has logged in, yeah. So we are all set.
Hi Lakshmi.
Sheila ma'am has
हॅलो
come.
हॅलो हॅलो 100 वर्ष आत्ताच विचारलं मी.
तिला fruitful 100 वर्ष.
आत्ताच बोललो कुठे आहे ICOG.
Evidence based. Yes, madam, we can start now.
So with your kind permission, can we start, Sheila madam?
Yes, please.
Please start the recording.
Yes ma'am, please start.
Then you start the recording.
Yeah, कर दिया है मैंने.
You started. Yes. So I welcome you all for day 3 of the FOGSI ICOG certificate course on abnormal uterine bleeding. And I would like to invite our ICOG chairperson, Dr. Sheila Mane, for her remarks. Dr. Sheila Mane.
Hello. Good evening, everybody. And I think it is really a very happy moment to see that our delegates are so much interested in certificate course and they really log in, and we have such a great crowd, I must say, that so many people are attending. And I would like to thank Dr. Lakshmi Shikande for conceptualizing this AUB scientific program and running it with zeal for 3 days. Okay, so I don't want to say much. We know that today I think we have discussions on AUB in all age groups.
Yes.
Yeah, and then there is a panel also, I think, which is on again perimenopausal bleeding, which is again very, very common scenario in our practice today, and the other modalities. And we have esteemed speakers, and I'm sure that third day also will be very interesting. So without taking much time, I wish all the best and hearty congratulations to whole team. Thank you. Okay, over to you, Lakshmi.
Thank you. Thank you. Now I would like to invite our ICOG secretary, Dr. Pratik Tambe, for his welcome address. Everyone knows Dr. Pratik. You don't need any introduction in real sense, but to introduce you officially, he is the dynamic, hardworking ICOG secretary, and he is IVF consultant and gynec endoscopic surgeon at Mumbai. So Pratik, your welcome remarks.
Thank you very much, Dr. Lakshmi Shrikande, ma'am, for convening a fantastic FOGSI ICOG certificate course on abnormal uterine bleeding. My gratitude to the co-conveners, Dr. Shashibala Bhosle, Dr. Shobha Budi, and Dr. Mita Gupta, who is today's co-convener. Today's proceedings are going to be centered around special situations and clinical integration. We've had 2 fantastic days, a lot of senior stalwarts as well as eminent clinicians giving us their trade secrets, imparting a lot of knowledge, which they've won through hard earned efforts, through decades of practice. We have more than 1,250 delegates who have registered for this 3-day course. I'm very happy to note that. And it goes without saying that AUB or abnormal uterine bleeding is the bread and butter of a gynecologist. It is the most common scenario which we encounter in daily clinical practice several times a day. And it goes without saying that we, all of us, need to be abreast with the newer developments, the newer diagnostic modalities, and the recent advances in algorithmic management and patient-centric management, which is the focus of today's program. So congratulations to the conveners, all the faculty. I'm very happy to see such amazing attendance, and I'm sure that all of the delegates will benefit immensely from the knowledge that is being imparted by all these senior stalwarts of FOGSI and ICOG. Thank you again for all your efforts, and I wish you all the very best.
Thank you, Pratik. Thank you for your appreciation and for your welcome address. Dr. Sarita Bhalerao is busy in the surgery. Whenever she joins, we will invite her to give her welcome address. She is consultant OBGYN at Bhatia, Sapi, Reliance and Breach Candy Hospital, and she is vice chair elect of ICOG. Next, please. Nilima. Yes, we would like to welcome Dr. Bhaskar Pal, who is the president of FOGSI, Dr. Suvarna Khadilkar, who is the Secretary General of FOGSI, Dr. Sadhana Gupta, and Dr. Ashok Kumar, who are the ICOG office bearers under all the able leadership led by Dr. Sheila Mane. We could manage this AUB course, and I thank each one of them, the FOGSI and ICOG office bearers, for all the support and guidance in conceptualizing and running this 3-day course. So dear delegates, I would like to tell you about the certain instructions. Please pay attention that attendance for all 3 days is compulsory. The MCQ link will be shared on the chat box. Also, we will be sharing the QR code once the course is over. You have to attend the 3-day course. You have to give MCQ test on all 3 days, and you have to earn 50% marks on all 3 days to become eligible to get a certificate. The certificate will be emailed to you within 1 month, but please note that this online certificate course is just an acknowledgement of attendance. Practice depends on skill and experience, which we do not certify. So we do not endorse any skills of the attendees. The videos, if any, will be put on ICOG website in due course. And for course material, you may communicate with the course coordinators. So I hope I am clear. Next slide, please. Now I would like to introduce co-convener Dr. Meeta Gupta, who is the Dean Academics and Professor and Head Department of OBGY at AIIMS, Vijayapur, Jammu. So Dr. Meeta will be conducting the further proceedings. So I am handing over to her. Meeta, please.
Thank you so much, ma'am. Today, as we come to the grand finale or the last day of this AUB certified course, I will just summarize the yesterday's session. We had a great stalwarts for us who had taken on different topics, be it the medical management, the surgical management, and of course, the most interactive panel discussion. The chairpersons for the medical management session were Dr. Rajshri ma'am, Dr. Jayarani ma'am, and Dr. Papu sir. And the speakers for the session were Dr. Indranil, who spoke on the non-hormonal therapy, that is the tranexamic acid, NSAIDs evidence and protocols. Dr. Apurv Dutt discussed on the various hormonal therapy, oral contraceptive, progesterone, and the LNG IUCDs. And of course, ultimately, Dr. Archana Dwivedi spoke on the newer and adjuvant therapies like GnRH analogs and selective progesterone receptors modulators, their current status in treatment of medical management of AUB. The second session was led by the chairpersons Durga Das sir, who was unable to join, but Dr. Renu Yadav and Dr. Arun Kumar Kuda were present. We had a galaxy of speakers, Dr. Divya, who spoke on the hysteroscopic interventions, Dr. Ashok Kumar Todani sir, who he spoke on hysterectomy, when, which route, and counseling. And of course, our very respected Lakshmi ma'am, who spoke about because Dr. Bharti Dorapatil could not come yesterday, she will be taking her session today. The third session was taken by Lakshmi Srikhande ma'am. Finally, we came to the last session, that was the most interactive panel discussion, which was moderated by Dr. Komal Chauhan and Dr. Madan Kamble. And we had the experts of national importance, that is MC Patel sir on the medical legal, and Ashish Kumar Mahopadhyay sir, who had joined despite having a tragedy at his home. The galaxy of panelists were Upma Saxena ma'am, Dr. Minakshi Ahuja, Dr. Narswani Sunkar, Dr. Pradeep Gangia, Dr. Hem Lima Gautam, Dr. Meenu Vash, Dr. Arpita Gandhi, Dr. Urmila, Dr. Rekha, and Dr. Chandra Purnaswamy. With this, we were able to summarize yesterday's session, and I take the permission of ma'am to go forward on today's session. Lakshmi ma'am.
Please invite the chairpersons of the first session.
Ji,
they all are here. Yeah.
Ji, ma'am. Thank you, ma'am. So with this, we start today's session, and I have the honor of inviting the chairpersons of today's session, Dr. Mahinder Ahuja ma'am. Ma'am is somebody who is known to each and everybody of us. She is President, Society of Meaningful Life Management. Her present designation is she is a director, Ahuja Healthcare, Dental and Infertility. She has dedicated 40 years for women and from adolescence to menopause. She was CEFOM's Vice President since 2018, CEFOM Secretary General 2014 to 18. She is the founder member of South Federation of Menopause, Vice President FOGSI 13-14. She was the President Indian Menopause Society 14-15 with affiliations to many professional bodies like ISAR, ISPAT, NARCHI. Ma'am was the editor-in-chief for Journal of Midlife Health from 2022 to 2024. Ma'am has more than 100 publications to her credit, and her original research is on age of menopause and determinants of age at menopause. She was also the editor-in-chief of Journal of Menopausal Health, as well as she's invited as a national and international faculty. We welcome you, ma'am, for today's session. The second chairperson for this is Arun Arora, sir, and I have the honor of welcoming him. I am more bound to more enjoyed to welcome him because he is from Jammu. Arun sir is director Pushpanjali Life Hospital Jammu. He is ex-HOD Government Medical College Udhampur, visiting professor fellowship ICOG, national advisor Indian Fertility Society, founder secretary Indian Fertility Society Jammu, advisor Jammu Obs and Gynae Society, vice president Indian IMA Jammu, contributed chapters to various postgraduate books and has been an invited faculty in national and international conferences. Sir is also the organizing chairperson of the FOGSI North Zone Yuva FOGSI 2026, which is going to be held in Jammu. Sir, I welcome you on behalf of ICOG. The third chairperson is Dr. Chitra. Ma'am is DNB DGO member NAMS.
Thank you, Dr.
FIAG. Thank you, sir. Dr. Chitra has a fellowship in reproductive medicine and minimally access surgery. She has done a certified course in advanced research methodology from JIPMER. She is presently from JIPMER. She has completed her MBBS from JIPMER. She has received various awards like Dr. Purnama
Dr.
Nadkarni
Meeta,
Award.
I think, Dr. Meeta, thank you. We'll go with the sessions, please. Thank you.
Thank you so much, ma'am. With this, I hand over the session to the chairpersons to invite the next speaker. Thank you so much, ma'am.
Yeah, Dr. Sampath is here, so let's invite her. Yeah,
हम
please
संपर्क
invite Dr.
connect हो
Sampath.
गया
Should I? Who will
Yes,
invite
ma'am.
Dr.
Yes, ma'am. Manindra, ma'am. You please introduce, ma'am.
Okay. Dr. Sampath Kumar is a well-known personality working in the FOGSI for so many years. MD DGO, FICOG, of course, Deputy Director and Professor of OG, retired, Institute of Obstetrics and Gynecology, MMC, Chennai. And she was the FOGSI Vice President 2023. She's the President Board of Studies, OG, TN, and Dr. MGR Medical University, 2015 to 2019. Member Board of Studies, OG Meenakshi Medical University, Chairperson FOGSI Adolescent Health Committee 2016 to 18, ICOG Governing Council Member and EC Executive Council Member, IMS Chennai. FOGSI President's Award for Best Committee Activities, IMA Doctors Day Award, FOGSI Dr. Durusha Distinguished Community Service Award, and FOGSI N.A. Pandit and Mrs. Shelja Pandit Women's Empowerment Awards, Karamveer Chakras 15 National Award for Adolescent Activities, Empowering Youth Award from Dr. Suchitra Pandit, HMS Champion Award at Vision 2020, and Certificate of Appreciation 2012 for Adolescent Health Activities from Sir Dr. Arul Kumaran. So she was the, I can't see the other further. I think we invite her for her talk on AUB in adolescents. To you, Dr. Sampath Kumari.
Madam,
We lost her?
but I think so.
She was here.
So we can go. Yeah.
Yes. So Arun, you can introduce Bharti Dore Patil and we can start with Bharti Dore Patil's talk. Please share the CV slide of Dr. Bharti Dore Patil. Yeah.
Thank you, ma'am. Dr. Bharti Dori Patil, she's well known to us since many years because of Indian Fertility Society Association. She is the head of gynecology department, Shri Hospital, scientific director, embryonic IVF Pune, national vice president IFS 2222, past national vice president FOGSI, past president IMA Pune, past president Pune Obs and Gynae Society, ex-chairperson Clinical Research Committee FOGSI. She has long association with journals also. She's executive editor, Journal of FSR, FOGSI Star Awardee 2016, Punya Ratna Awardee 2014, Women Icon 2015, Inspiring Gynecologist 2017, Sri Shakti Award 2022. She has been really an inspiring and tall figure. Welcome, Dr. Bharti Dori Patel, madam.
Thank you so much, Dr. Arun and the team ICOG, in special Dr. Lakshmi. I thank Dr. Sheila Man, ICOG President. Then I would like to thank the chairperson, Dr. Paninder, as well as Dr. Chitra. And I would request now Dr. Lakshmi to share my presentation.
Okay. I will share.
And this is something very interesting topic, abnormal uterine bleeding. I remember when I was vice president along with Dr. Alka Kriplani, we had with FOGSI and gynae endocrinology done a AUB guidelines, GCPR. And I think after that, Dr. Lakshmi ICOG had taken up another, I think, review guidelines on AUB, because this is very, very pertaining topic to your practice. It is very important to deal with this type of patients. So, and in these patients, we should know how can you spare the uterus also when you have actually fed up with this abnormal uterine bleeding. So, next slide, please.
Yeah.
I think I'm troubling Lakshmi. So the burden of AUB and the case sparing the uterus, we will see majority, that 30% more than approximately are at this age will face the AUB. And 1 in 3 consultations in OBGYN actually will related to abnormal bleeding. And 70 to 80% of them are structural AUB, that is PALM, you know that, and which is for the organ sparing approach. So that's how we should understand. AUB doesn't mean the full stop, and it's not that if the uterus has to be out, but we have to see how the uterus can be spared. So when and how, why we will spare, preserve the fertility potential when the patient is in the reproductive age group, avoids the morbidity, recovery time, and the cost of hysterectomy. It maintains the pelvic floor support and, very importantly, hormonal and sexual function. And it aligns with the patient preference in a population marrying and conceiving little later in the life. So treat the cause, preserve the form, and intervene with precision, not excess. This is actually the principle. So the guiding philosophy is restore physiology while conserving the organ whenever clinically sound. So next slide. Next. So we know, I think 3 days has been, so previous slide. So 3 days has been, now you are learning about AUB. Next slide. And we all know now the terminologies has been changed, and FIGO has classified this as a palm point. So we usually in the counseling tell the patient this is a structural defect or there is a non-structural defect. And that's how you start classifying and identifying the problems and accordingly start addressing it. So whenever there is a surgical structural abnormalities there, especially when there polyp adenomyosis or a leiomyoma, you have to think about surgically addressable issues in this patient, and you can spare the uterus in this type of patient. So we'll see how. Next slide, please. So the goals of uterine sparing surgery should be control bleeding, because patients are fed up with this abnormal bleeding, heavy as well as abnormally coming anytime. preserve the fertility whenever she has been in the reproductive age group and she desires for the pregnancy. We have to maintain the anatomy because it definitely makes uterine integrity, pelvic support, and hormonal axis work in place. And it minimizes the morbidity, especially when suppose you have not been in the place where there is a competent surgery and surgical facilities are there, the lower complication rates, faster recovery versus hysterectomy. Next slide. Next slide. So the patient selection is extremely important. No, previous slide. Patient selection is important. See which patient to spare the uterus, which patient you should not be sparing the uterus. It depends on your patient selection. The general principle is first you should ask whether the patient has fertility desire. If she have a reproductive plans ahead, and then accordingly you start taking the action. Age and proximity to menopause is also very important. Pathological size, number, and a location of, say, especially submucosal, intramural, and a subserosal location and the lesion, which burdens determine the feasible surgical route. Symptom severity and anemia status is also very important. And comorbidities and surgical fitness is extremely important to take the patient for surgery or not to take the patient for surgery. So essentially, you have to do the patient's pre-operative workup. And the pre-operative workup, first and foremost, is transvaginal sonography with saline infusion or 3D ultrasonography is extremely important. And if you have a suspicion, go ahead with the pelvic MRI to diagnose or map exactly what is the size and the location of the fibroid or the polyp, or if at all the patient has adenomyosis, whether it is a complex or whether it is a diffuse or it is a focal adenomyosis. So office or diagnostic hysteroscopy for cavity assessment, but only office or diagnostic hysteroscopy may not be only the straight investigation for her. Probably if suppose you have a sonography or MRI, you can plan the same setting, both hysteroscopically operative patient. Endometrial sampling to exclude hyperplasia and malignancy. I remember when we had that AUB guidelines, when we designed through FOGSI and Gynae Endocrine Society, we had said if the patient is more than 40 years of age and she has an abnormal uterine bleeding and she has an endometrial lining which is more than 5 to 8 millimeter, please go ahead with the endometrial sampling. It's a very easy way to do. Patient will not get worried about it, but to straight away go OPD procedures must be exclude hyperplasia or typical hyperplasia and malignancy. Extremely important. And I think now in India, especially, we are all taken up that endometrial biopsy. Hemogram, iron studies, coagulation profile, DSH, you all know that all investigations has to be done. Counseling on the fertility goal and a recurrent risk and alternatives has to be discussed with the patient, especially when you have been doing a myomectomy. How big is the myoma and how long you can wait for the further fertility options. So now selecting the procedure by pathology. Now, if a patient has a submucosal fibroid, that type 0 to 1, any age, fertility desired or not, cavity is distorting, you have to go ahead with a hysteroscopy, myomectomy. There is no option. It's straight green channel. You have to go ahead. Intramural fibroid, cavity sparing, fertility desired, patient is symptomatic and the size is more than 8 to 10 centimeter, laparoscopy, and if it is not feasible for you, open myomectomy can be done for this patient. But laparoscopy route is the most easiest and most, you can say, acceptable everywhere. So multiple large fibroids are there. So many times we see multiple fibroids are there, and overall you see that the uterus is completely a very big size, and patient has a fertility not a priority. She has failed medical treatment, probably myomectomy or UAE is very opt for that patient. Now coming to very important diagnosis is a focal adenomyosis or diffuse adenomyosis, where actually there is a catch. If the focal adenomyosis is there and fertility is desired, localized disease on MRI could be very properly seen. Adenomyomectomy is very important for that patient to get a pregnancy outcome or the implantation, proper implantation. Diffuse adenomyosis is little different. If the patient is fertility desired, but the disease is extensive and you just can't locate, it is completely on the posterior wall or in the myometrium, probably patient has to go for embolization or conservative cytoreduction in this patient. Now, very easy diagnosis is the endometrial polyp. You all know that. Any age, patient is a AUB and a infertility workup has been done. You know, straightforward, very rewarding. Anybody can do hysteroscopic polypectomy. Only you need to map that polyp and very properly from the base the polyp has to be removed. Refractory AUBE, no structural lesion and fertility is completed, failed medical treatment, childbearing is completed, probably, and she is not willing for the uterus to be removed, endometrial ablation is the choice of method. So these are actually the videos which you can see the myomas are being resected. I think we can go ahead. Next slide. Next slide, please. So the spectrum of uterus sparing techniques, no, before. A spectrum of uterus sparing techniques from least to most invasive, matched to the pathology, fertility intent, and patient fitness. This is how we give the option to the patient also. So you have to understand, you have to make the patient understand if at all she wants to do the uterus sparing techniques, these are the various modalities you can have. Hysteroscopic resection, if there is a polyp or myomas are there inside, if there is a septum or synechiae. Laparoscopy or robotic myomectomy is another choice now when it is intramural, which is intending into the cavity or in the cavity. Subserosal fibroids, minimally invasive enucleation can be done. Open myomectomy, when there is a large, multiple, repeated, complex fibroids, unsuitable for minimally invasive procedure, probably open myomectomy. But very rarely nowadays we do, but it is possible. Adenomyomectomy is very important. And uterine artery embolization is another very important focused uterus sparing techniques. Don't deny the patient. Provided you should have interventional radiologist, the option can be given to the patient. Patient has to understand how much recovery will be there with this procedure. All plus and minuses has to be discussed with the patient and interventional radiologist, and your techniques technologically update in the hospital is very important for this. Endometrial ablation, again, we used to do lot previously, but it has now reduced because there are a number of other modalities at home. Destructive technique it is for refractory AUB. So yes, next slide. So hysteroscopy, myomectomy or polypectomy, what has to be understood? Indication, FIGO type 0, 1 submucosal fibroid less than 4 to 5 centimeter. Please remember that is ideal. Or you have to have 2 sittings. One sitting, it will be very difficult to understand the saline overload and very difficult for the patient to come out of it.
Sorry to interrupt you, ma'am. Your time is up.
I think it is a last slide.
Okay.
So resectoscope and distension media, that is normal saline under the controlled fluid deficit monitoring is very important. Monitor fluid deficit very closely. Pre-op GNH agonist are very important. Second look hysteroscopy, very useful for large myoma, and combined with concurrent laparoscopy, or many a times we do under sonography control also, means after the surgery, we just allow the sonologist to come and just check how far the myomas has been removed. So next slide. So I think with this, I think same I have discussed with all these things. These are all techniques of uterus sparing technologies for AUB, abnormal uterine bleeding. And I was very happy that those guidelines were taken up by all across India and people started understanding how it has to be done. And now ICOG again had given a very big importance to AUB because it's a day-to-day practice topic. And thank you very much, Dr. Lakshmi, for this invitation, and Dr. Sheila, Dr. Bhaskar Pal, and all to go ahead. Thank you. This is it's okay. I just discussed with this all.
So thank you. 98865.
Dr. Arun? Dr. Arun, are you here? Maninder, you can conclude.
Yeah, okay. First
Hello,
of all,
Bharti. Nice to see you.
We didn't see her, we just heard her. Anyway.
Maninder, my camera is not working here. I am at Haridwar right now.
Anyway, I'll talk to you later. Yes.
Yeah,
First of all, thank you.
Actually, I
First
have
of all,
come to Haridwar. Maninder,
yes.
I could see you, very lovely face and same energy, same enthusiasm. I love you.
Thank you. Thank you. Thank you. I love also.
I could not on the video because my camera, because I'm at Haridwar, and from this place I'm talking to, and I'm bringing all the blessings to all of you. Thank you.
But thank you, Bharti Patel, because your voice is still the same, and I love that voice and hearing to you. And you gave a wonderful talk. But first of all, I must thank ICOG, all the faculty, Secretary Dr. Sheila, President Dr. Sheila Mane, Chairperson rather, Secretary Dr. Pratik Tambe, Convener Dr. Lakshmi, and Chairperson elect Dr. Sarita Bhalarao, and others who are there as the office bearers of ICOG. And congratulations for bringing up this very important subject, which is just like a common cold of the gynecologists say. And as the Pratik also said, it's like the bread and butter of all the gynecology. But still, the things which are very common still needs very important discussions, because the science goes on and sometimes the guidelines also go on changing and everything. So I have been here at least first day I was there yesterday I was partial, but this day today I'm going to be there attending all the sessions, and I have been really impressed by the way the speakers have spoken and taken the details in there. And Bharti, about your subject, I think it's very beautifully explained by palm point classification, and you have simplified that we have to assess initially according to the age of the patient, according to whether she wants her simple fertility sparing or not sparing, and then depending upon her severity of the symptoms, then she has to decide what type of surgery we will be doing. Now, if it's a simple polyp, histoscopic polypectomy can be done. If it's an adenomyosis, then we can do the adenomyomectomy. But if it's a diffuse, then perhaps uterine artery embolization. And if the bigger fibroid or myomas are there, then of course we'll have to either go the laparoscopic surgery, or depending upon robotic surgery, whatever the interventions are available. So you have taken the subject very nicely, and thank you very much again to the organizers for giving me this opportunity again and being active on these fields, which I love being here. Thank you again, and thank you for the wonderful talk.
Thank you, Maninder. Yes, Pratik wants to say something. Yes, Pratik, please.
I just wanted to speak 2 sentences. One is, it's lovely to see Dr. Maninder Ahuja again on the ICOG platform. Thank you for being here with us. And we have 2 candidates for election, Dr. Bharti Dore Patil and Dr. Sampath Kumari. Officially, I would like to wish you all the very best. Please go ahead.
Thank you, Pratik. Now let's, Dr. Sampath, please start. You have been already introduced. Yeah.
Yes, madam. Yes, madam. Here there is no signal. I don't know when it will get disconnected. Good
No
morning,
issues.
good evening to all. And thanks to Dr. Sheila Mane, Dr. Pratik and Dr. Lakshmi Madam for this wonderful opportunity. My topic is on adolescent uterine bleeding.
Madam, you are muted. I have sent you an unmute
Yes.
request.
Net
Yes,
connectivity is not there.
So
yes,
you can switch
adolescent
off your
uterine.
video. You can switch off your video, Sampath.
Yes, madam. Yes, madam.
Hmm.
I thank Dr. Sheila Mane, Dr. Pratik Tambe, and Dr. Lakshmi Srikande for this opportunity. My topic is adolescent uterine bleeding. The next slide. Next slide. As Pratik told, I am contesting for president. The adolescence is it is neither between, they are neither the children nor the adult. It is between the childhood and the adulthood. The next slide. The WHO has classified adolescence into early, middle, and late. So the menarche normally happens at the middle adolescence, that is 14 to 16 years. The next slide. Why we talk about the adolescence is the adolescent populations. 23% of our population is adolescents. That is the reason we talk more about this adolescent and particularly this AUB. The next slide. The challenges, there are a lot of challenges in the adolescence. 45% of boys and girls are undernourished, and 50% are sexually active, and 4 to 5% are drug abuse. 50% of the new HIV cases has been between the ages of 10 to 15. Next slide. The menstrual cycle, as all of us know, the full of proliferative and the secretory phase, and the ovulation that happens during that 14th day. The next slide. With the adolescent, most of the time, the ovulation is not present. That is the reason the bleeding during the adolescent is anovulatory. Next slide. Next slide. The bleeding is almost the types. The types is mainly depends on the disorders in the regularity and disorders in the, and the next slide, disorders in the amount of flow and disorders in the duration of the flow. These are all the disturbances which happens during the bleeding. So that is the reason this is classified as Bharati Madam was telling. Next slide, palm coin. That is the bleeding which is due to the structural is palm and non-structural is the coin, which was described already. And the causes of the bleeding in adolescent. The next slide are, next slide. Mainly 90% is due to the anovulatory bleeding, physiologic anovulatory bleeding, and pathologic anovulatory bleeding. That being the endocrinopathies. Always, whenever the bleeding is heavy in adolescent, we have to rule out the thyroid and the prolactin. The stress, eating disorders may be present. And finally, the PCOS. The pregnancy complications, always it is in the heavy menstrual bleeding. We have to rule out the pregnancy. The genital tract infections. That is also mainly the tuberculosis, the coagulation disorder, whether it is present from the childhood, that has to be elicited. And finally, the structural lesions, benign and the malignant lesions, which is very rare in case of the adolescents. Next slide. So when a girl comes with a history of adolescent bleeding, elicit the history when she attained the menarche and what was her bleeding time, whether it was regular or irregular, whether she had sexually active. That question we have to put a leading question. And whether she has stress and whether she is on any tablet like a thyroid, tuberculosis, that history has to be elicited. Next slide. And they have to maintain it this, how many pads they are using, whether the pad is fully soaked or whether it is halfway soaked. This has to be elicited for the bleeding. So then how are we going to evaluate? Next slide. So we are going to evaluate the pregnancy, thyroid and prolactin, and then the bleeding disorder. Next slide. The common, as I told, is an ovulation. And finally, the structural causes, myomas, medications, foreign body, and the sexual assault. So the next slide. The anovulation. Adolescent always have, next slide, ma. The anovulation, because the ovulation normally starts between the 2 to 4 years after. Nowadays, the menarche is a little earlier. So anovulation is the common cause of AUB in adolescents. Why the anovulation? After that is no cyclical production of progesterone, the unopposed estrogen. The endometrium is lining is abnormally thickened and spontaneously superficial breakage, which leads into the asynchronous bleeding. So the recommendations on laboratory test. Next slide. What are all the tests we are going to do is complete blood count. It is needed to see the assess the anemia level, whether it is mild, moderate, or severe. That has to be done. And the thyroid and prolactin, as I told, it has to be ruled out. And the coagulation disorder, whichever it is present, it has to be ruled out. And depending on the anemia grading, the other anemia investigations can be done. Next slide. The treatment in case of when a girl comes, we have to see whether it is the anovulatory bleeding, that is mainly with the hormonal, and do the investigations, rule out pregnancy, thyroid, prolactin, tuberculosis, and the coagulation profile. And the treatment we are going to do is mainly the iron supplementations. And sometimes the combined oral contraceptives, estrogen and progesterone. Mainly for the adolescents we use is only the progesterone. Progesterone is normally used for the adolescents. For a mild bleeding, which is not severe, in that cases, we can start with the non-steroidal anti-inflammatory drugs, NSAID. The bleeding can stop, tranexamic acid, mefenamic acid. This can be given. And if it is not controlled, then only we go with the hormonal combination, preferably progesterone. And if with the progesterone, the bleeding in between spotting are present, we go with the combined oral contraceptives. GnRH analogs can be used, but they are very, very rare. Next slide. So we are going to classify the AUB as mild, moderate, severe. If it is the mild, it depends on the hemoglobin, whether it is less than 10 or 7 to 10, or the hemoglobin is less than, more than, less than 7. 7 to 10 and more than 10. Most of the time, the girls, they will be doing the schooling and they will not come. Mostly, they will come only in the moderate and the severe anemia. Mild cases, the hemoglobin, we can treat the patients with the NSAID such as Brufen and the tranexamic acid, and the good iron-rich diet itself is enough. Next slide. If it is the hemoglobin is going to be 10 to 12 itself, we can give the iron tablets and ask her to continue and re-evaluate the case after 3 months. Next slide. So this is the way we are going to re-evaluate. First to give them tranexamic acids and then the iron diet. Next slide. Moderate. If the hemoglobin is between 7 to 10 and the bleeding is moderate, there we go with the progesterone. The progesterone normally we used is the medroxyprogesterone acetate or norethistran acetate. It can be 5 milligram or the 10 milligram. It can be given the cyclically. That is first to stop the bleeding. It has to be started with the 30 milligram, and then it has to be given for 1 week and gradually reduce the dose. And once the withdrawal bleeding happens, from the next cycle, you can continue the progesterone from the day 2 or from the 14th day, that is during the ovulation time for 10 days. So the progesterone can be used cyclical or with the from a 10-day cycle. If the bleeding with the progesterone in between the girl is having spotting means, in that cases, you have to go with the estrogen combined oral contraceptive pills. Next slide. Low dose of estrogen, that is 30 microgram, can be used. Next slide. When we use the estrogen, sometimes they may be having vomiting. So the 4 to 8 milligram of ondansetron can be given. The next slide. See, these are all the routine things which I have told. Medroxyprogesterone 10 milligram, norethistran 2.5 to 5 milligram. It can be given cyclically or from the 10th day. Suppose the girls, next slide, some girls may not be comfortable with the oral. In that cases, even you can go with the injections, which is available even in the government setups. That is the depot medroxyprogesterone acetate, which can be given once in 3 months. But most of the time for heavy menstrual bleeding, we don't use that. Next slide. Next comes the severe, next slide, ma. Next slide. Severe menstrual bleeding. So if the hemoglobin is less than 7, next slide. If it is very, in that cases, you have to go with the combined oral contraceptive pills. This can be given 30 to 50 milligram. That is 2 tablets of the combined oral contraceptive pills can be given once the bleeding is stopped. And it has to be given every 2 to 4 days. Every 6 hours, 2 tablets, or every 6 hours, 1 tablet. Stop the bleeding, and then you go with the cyclical use of the oral contraceptive pills or with the progesterones. In the severe cases, simultaneously, we have to give the blood transfusion and supplementation of the elemental iron. So the hormone therapy which we recommend is 30 to 50 microgram ethinyl estradiol given every 6 hours, 2 to 5 days. Once the bleeding is stopped, gradually reduce. And then after the withdrawal bleeding, you go with the OC pills low dose cyclically or with the progesterones cyclically. In severe cases, next slide. So in some severe cases, if the bleeding is continuous, no, you are going reverse. Next slide. In that cases, we can go with the 25 milligram of IV conjugated estrogen. It can be given every 4 to 6 hours, up to 2 to 3 times. Once the bleeding is stopped, again you can go with the oral contraceptive pills. So the blood transfusion, as we have, next slide. As we have discussed, the blood components can be given, the whole blood or the whatever is needed, the packed cell, cryoprecipitate, depending on that, blood transfusion should be given and the anemia has to be corrected. The next slide. With this medical management, if it is not corrected, then only in some cases you may go for therapeutic curettage, but it is not at all essential for the adolescent girls. Next slide. Next slide. Next slide. Then you have to, the common causes of the thyroid and the bleeding disorder has to be ruled out. And finally, if there is a history of amenorrhea and the continuous bleeding means, rule out the pregnancy, and then you have to treat the PCOS. PCOS itself is an entirely separate chapter that can be discussed with the PCOS topic, I think. So when a girl with the bleeding comes means, first you have to rule out thyroid, prolactin, bleeding disorder, tuberculosis. Then categorize us as mild or moderate or severe. Depending on that, you have to treat. Mild cases, one need tranexamic. Moderate to severe, go with the progesterone. If it is not controlled, if spotting is present, go with the oral contraceptive. In severe cases, you can go with the 25 milligram of the unconjugated progesterone. Simultaneously, blood transfusion has to be given. Thank you. Always don't take the bleeding in adolescent as a casual. You have to counsel the patient if there is any bleeding disorder, heavy bleeding means come. Once again, I request all of you that I am contesting for FOGSI president. Please support for me. Thank you. You can stop it, Nilima. Thank you, madam.
Thank you, Sampath. It was a very comprehensive talk. I can see Arun, if you are here, you can conclude. Arun?
Yes, madam. Yeah, thank you, Sampath ma'am. Excellent presentation covering all aspects. I'm audible, no?
Yeah, you are audible.
Yes.
Yes, ma'am. So how about you looking for rarer coagulation defects?
Coagulation defects. See, most of the time, if it is the coagulation defects, before the puberty itself, they will come. Oh, signal is with the history of a bleeding per comes, bleeding per rectum. That now the incidences are during yearly, we can see at least 5 to 6 cases.
So practically now it is around 15 to 20% of adolescents present with the coagulation disorder. So that becomes a very important investigation before you really start the treatment. You can look for even the platelet counts or the routine part, no? And maybe von Willebrand disease, etc. So you have to rule out those things and then move. Because earlier we were all, missing these things. Rather, we were all focusing on hormone. Because all I know, and around 80-90% are there, but then we have to rule out all those basic things also. Thank you, madam.
Sure.
Thank you, and wish you all the best for your present.
Sometimes.
Thank you so much.
Okay.
Thank you, madam. Thank you, Mahinder, madam.
Chitra, you can introduce the third speaker. Yes, Maninder, please.
Madam,
Please comment.
Sampath, very nice talk, madam. All the best wishes for your FOGSI president election.
Thank you, Chitra. Thank you. Thank you, madam.
Yes, Chitra, please introduce.
It's my privilege to introduce the next speaker who is going to talk on the most important topic. It's my pleasure to introduce the next speaker who is going to talk on the most important topic, the post-bleeding. Did the module
You can switch off your video,
and
Chitra.
director and consultant in menopause Tanvir Hospital. Yeah. In menopause, postmenopausal and osteoporosis. She has a lot of publications, awards to her credit, and our personal interest is like reading and gardening. And we are really waiting to hear to you, ma'am. And over to you.
She is the apt person to speak on postmenopausal bleeding because she has done lot of work and lot of publications in postmenopausal bleeding. Yes, Mita, welcome.
Yeah, a very good evening, everyone, and thank you so much, the FOGSI and especially the ICOG team, for inviting me for this topic today. The topic is postmenopausal bleeding, and I would say the endometrium is such a wonderful tissue in our body. It is a nurturer. It is actually an essence of life. And I would really like to show this particular picture, which you see a submucous fibroid, which we delivered after we delivered the baby after cesarean section in a case of IVF. So it never fails, medicine never fails to amaze us. You know, you find so many things which go against the traditional thought process. And you have it as a nurturer. And I think that's one of the most fantastic, fascinating tissue in the body. But it can cause problems as one ages. So this is one of the topics because endometrium is one of the main areas which we are going to talk about when you're talking about the bleeding. So the definition is bleeding happening after 12 months of amenorrhea. But we start investigating 6 months after presumed menopause. We say presumed menopause because we are not going to do an FSH for everybody. So if a woman in that particular age group, 40, 45 age group, doesn't have periods for 6 months, and you're ruling out all other secondary causes of amenorrhea like the prolactins and thyroids, and then she deserves evaluation, you have to look at especially the endometrium. So the history becomes very important. You start investigating, and that is the definition. So we're going to come to this very important aspect of postmenopausal bleeding, which is a recurrent bleeding. So you're going to look right from the vulva into the uterus, the entire genital system, the urinary tract, as well as the lower intestinal tract. So you have to look everywhere. So postmenopausal bleeding is a symptom. But what we are worried about at that age is the malignancy. So that is the most important diagnosis which we want to exclude. All other things which happen with the postmenopausal bleeding are all manageable. But malignancy is something that you cannot afford to miss out. But the problem is being compliant, too vigilant or overreacting. So you have to have a balance over there. So the paradox is the bleeding becomes less frequent with time since menopause, but the probability of malignancy increases with ages. So the estimated annual incidence of postmenopausal bleeding, say just immediately or within the first 3 years of menopause in a study has shown 40%, but beyond 3 to 5 years after menopause, it reduces. So the incidence of the postmenopause bleed reduces from 40% per annum to 4%. But we all know that one of the symptom of endometrial cancer is 80 to 90%. And that is an advantage we need to take. The gynecologist has to take in. Unlike ovarian cancer, which is very, very silent, this presents itself. And that is where the diagnosis lies. So age since menopause matters very much. So the estimated incidence of endometrial cancer increases as the age increases from 5 to 10% in the early postmenopause to 20 to 25% in late postmenopause. Now, what is really, really important is the term recurrent postmenopause bleed. When do you say that? The definition is whenever a new bleed, fresh episode of bleeding happens after an interval of 6 weeks following resolution of a past bleed, where you must have investigated, that is called a recurrent postmenopausal bleed, and we are going to discuss a little bit more on that. So remember that there is something also which is non-estrogen dependent. That is the type 2 non-estrogen dependent cancer, which can happen in the endometrium. So most commonly, what we face is the estrogen-dependent endometrial cancer in postmenopausal bleed. And again, remember, it's only a symptom, and malignancy is the diagnosis we have to do. And this happens in 3 to 5% of the cases. So you have investigated and you have found it to be benign. You really didn't find anything, inadequate sample, or it was an atrophic endometrium, but she has repeated these. Never ignore, because the P3 abnormal mutation, which we find in the molecular studies, indicates that it can happen in an atrophic endometrium, and less than 4 millimeter is not a solace for us. We cannot rest on it. Moreover, so the clinical implication is whenever the woman is symptomatic, don't rely only on your biopsy findings or even your biopsy finding, even on the ultrasound. Even the biopsy finding, you have to be vigilant and you have to take it forward from there. And we will also be discussing the management. So an endometrial thickness by a transvaginal scan of equal to or less than 4 millimeters has a very high negative predictive value. So 99% of the times you're not going to find an endometrioid cancer, but at 1%, there can be those, the serous cancers and other stromal cancers. And some of the stromal cancers, that is, which are not arising, say, from the epithelium, but from the basement membrane, they can go into, so instead of projecting out your hysteroscopy, everything, your scan, everything may look normal. In the early stages, you can have it from the basement membrane going into the muscle. So the only thing that can have is, scanty bleed once in a while. So that itself, should guide you that recurrent bleeding is a warning signal to be more vigilant. So the recurrent persistent postmenopausal bleeding overrules the thickness. Repeat investigation, even if your sample has shown atrophy. Do not read the same incomplete test when the clinical signal persists. Older age groups, a recurrence of polyps, especially polyps are not supposed to recur after menopause because there is nothing which makes them grow at that time. So anything that is recurring and short recurrence, interval of recurrence, be vigilant. And here comes in the role of MRI. MRI is not the first line of management or even the second line of management when you are in investigation in a case of postmenopause bleed. But what it is where do we do it? Yes, there are certain clear-cut indications where you need to do it. When you're doing a scan and the TVS is inconclusive, you're really not able to visualize the entire endometrium, or the EM junction is not clear, and you're suspicious of the color Doppler, and the biopsy report comes out as insufficient, or repeatedly twice you have done it with a recurrent bleed and it's always benign and it's not showing anything, and hysteroscopy is technically difficult, or when you see nothing is seen and the symptoms are persisting, then an MRI with contrast, especially to pick up the blood vessels over there, plays a big role. And of course, medico-legally also, it saves you when the woman doesn't want to go for a surgery. So benign is very common. So having said all that about the endometrial cancer, the pattern, this is from an Indian study, that the frequency pattern reported in a postmenopausal bleeding is mainly, it is either polyps or hyperplasia, simple hyperplasia, atrophic vaginitis, atrophic endometritis in 30% of the cases, the use of MHT, not just MHT, other drugs, other medications, even some antihypertensive, anticoagulants, soya, in the estrogen-based products like ginseng. So any of these can precipitate in a vulnerable woman the bleeding. So 30% could be your external estrogens, and sometimes the BMI, of course, will add on to it. And the proliferative and secretory endometrial, secretory is generally not seen. It's only the proliferative that is seen in postmenopause. And the miscellaneous is the other from the other aspects like trauma, or I had two times I had a horrible 2 post-coital bleeds, which we had to suture under general anesthesia. And sometimes you have the forgotten pessary. Of course, all of you were experiencing the forgotten IUCDs inside the uterus coming with the pyometra also in some of the cases. And endometrial cancer is what we've also spoken about. Fibroids is also an entity because we have to keep, and now adenomyosis also, we're probably looking at it even in postmenopause, and we're finding them more and more. So the workup must cover 3 main compartments, that is the endometrium, the vulva, vagina, and the cervix, and with the systemic effects and the iatrogenic medications that we are looking at. So it's a detailed history which becomes very, very important. So when the woman comes to you the first time with a postmenopausal bleed, of course, it's very, very important. It's not just the bleeding pattern or whatever written over here. I think the age and years since menopause becomes very important. Apart from that, the pattern of the menstrual history that has happened before she has entered into menopause can give you lots of clues as to what she must have had. Sometimes they have endometrial hyperplasia and probably would have put them on progesterones, and they don't come back for the repeat biopsies. And suddenly they put on more weight, more estrogens, and they may end up with some, again, an endometrial hyperplasia later, or even endometrial cancers if they're genetically predisposed. So we really have to look at the past history, obesity, nulliparity, unopposed estrogen therapy. Now we are having more and more of them, especially people traveling from the other countries, late menopause, starting estrogen therapy without the progesterones, or MHT without telling them that they're going to bleed initially when they are on therapy, even after a long time, family history. So all this, we need to take a complete good history. The medication history gets important, how the bleeding is, whether it's recurrent, postpartum, all of them lead to the diagnosis, of course. And the examination is, the BMI is very, very important. Never forget the local examination. Before even you put on the speculum, have a look at the vulva, look at the vestibule, look at the rectum, look at the urethra. Sometimes you may have urethral coruncles which bleed, and the varicosities over there can also cause a problem. I had 2 cases of those vulval varicosities which would bleed along with the atrophic vaginitis. Bimanual examination, never forget the speculum, and of course consider the other areas of bleeding. So very, very important is the TVS triage. That is, measure not just the endometrium, look at the morphology, look at the Doppler, look at the context, that is the entire picture. You're not just going by the endometrial thickness. I think the AUCOG guidelines on postmenopausal bleeding latest has also revised its points when you come to the thickness. Earlier, the entire literature was flooded only with thickness, and we would go paranoid as to what is the thickness that we need to start biopsy in an asymptomatic and a symptomatic woman. I think we should go beyond that, because thin is not the endpoint if the symptoms persist, and we are very particular about that. Measuring the endometrium by the ultrasound, the way it has to be done, the Doppler, the way it has to be presented, is very, very important. If somebody is not able to visualize for whatever reasons, has to be documented well. So blind biopsy is useful for diffuse disease, but not for focal disease. Of course, the hysteroscopy direct biopsy is the gold standard, but like we have put it, it's always with the best that you can give to your woman with whatever you have. And I think Pipple device is one of the most fantastic devices that has been done for postmenopausal bleed or for any other office procedure where you need the endometrial sampling. Pipple biopsy is the most doable, where nobody can say that they have not done. So there is a practical one-stop. So sorry, I'm so sorry. So I'll just quickly go through the management. The management is atrophic, basically based on histology. Just give me a minute more. And so this is the atrophic endometrium. And this is how it will look like, the proliferative endometrium. In a postmenopausal women, what are you going to do? So either you're going to do a follow-up or hysterectomy. Endometrial hyperplasia, yes, again, progesterones, again, you decide depending upon the thing, but when you follow them up or go for a hysterectomy. Endometrial intraepithelial neoplasia, yes, of course, a hysterectomy. The cancer, and then you have the other intracavitary lesions to go with. So, but be vigilant, thin endometrium, focal echogenicity, benign or insufficient Pipple, follow-up, then look at the source of bleeding. So symptoms, risk profile, morphology, endometrial thickness, histology. All of them have to be put together when you're taking care of your thing. And this is the source that we have done, and the latest guideline is out there. Thank you so much for the patient hearing. And I'm sorry if I had to rush through the last part.
No, not at all. It was a fantastic, very, very informative talk. Yeah, Chitra, please. Then Maninder.
Yeah, ma'am. Yes, ma'am. Meeta ma'am, it was a very excellent presentation on this postmenopausal bleeding, and your slides were very good, and you are more your diagrammatic representation and the pictures, images, it just speaks a lot. What is one thing which we don't know is, if a patient comes with recurrent postmenopausal bleeding, we don't have the cause, and you showed it very nicely how to evaluate them, either by the MRI to look for those things. Now, I wanted to ask, ma'am, in spite of if we know the cause, yes, we can treat accordingly. If you don't know the cause, but this patient come with recurrent episodes of either bleeding or spotting 1 or 2 days, what will be, how we are going to evaluate her? We evaluated her, everything is normal, then should we hysterectomy is the treatment? treatment or what else? Anything could be done?
Correct. I think that's an excellent question because we really don't have answers. There are no guidelines to guide us as to what to do. All the guidelines say it's better in such cases, it's better to err on this side, do a hysterectomy if it's a recurrent bleed. Because I have had two cases. One was a young woman, young in the sense, 40 plus, and that's in the perimenopause, and one is postmenopausal, like this recurrent bleeding, where we were following up, and two cases of stromal tumors which were not projecting into the endometrium. They were going into the myometrium, and the MRI also couldn't pick up because it was like in situ.
Okay. Okay.
In situ. In situ. So if you have an excellent pathologist, then you will realize, so many times you may miss the in
Yeah,
situ.
true, man. True.
It may come
Yes.
normal. If an expert who does lots of sections and goes into the details, so that stromal cancer was an eye-opener. So I think you have to follow the symptoms rather than depend only on your investigations.
Yes.
Or on the side, here is one place we go for a hysterectomy.
Okay. Okay. Yeah, that's
This
what
is
we don't in our
experience-based.
Indian settings.
This is experience-based, not evidence-based.
Yeah. Yeah, but you told me in this thing, at least 3 to 5% chances that the patient can have endometrial institute. It's better like you operate because they might lose a follow-up. They can come in the advanced stage. That will be more
Absolutely.
morbid to the patient. Very
Absolutely.
excellent presentation. I really loved your slides and your depiction. Thank you. Someone was asking your book. That's you can put it at the end, madam, in the chat box. How to take your book?
Yeah. So the book is going to be available on our Indian Menopause Society website, and also probably very soon even on the Amazon.
Okay. Thank you, ma'am. Thank you.
Yeah.
Thank you.
Lakshmi, should I take it?
Thank you.
Yeah,
Maninder, please comment.
Yeah.
Yeah.
Yes. I think it was a wonderful presentation, covered everything. But for our PG students' sake, I guess going to add a few points that we are living in an aging population, but that aging population is not healthy population. So that's why we have more incidence of cancers now. So the women which have to spend years in menopause is increasing, but so is the obesity, so is the hypertension, so is the diabetes. So all this is leading on to the increased incidence of carcinoma, maybe frank or like the Mita said, carcinoma in situ. So ACOG has come up with the latest guideline. They say treat all postmenopausal bleeding as cancers until unless proved otherwise. So that I think hypothesis should be taken, and from more, and you start from the vulva to the vagina to the cervix and the uterus, and go to the even ovaries and everywhere, but diagnose it. And if you cannot find anything, but the bleeding is persistent, it's recurrent, it's better to do a hysterectomy than to miss a diagnosis and miss a life, because then they won't come to you again. They'll think, yeah, okay, this bleeding is normal. So any bleeding occurring after menopause, 6 months of that, or maybe after 1 year of that, is considered abnormal until unless proved by all the investigation which Nita has already highlighted, that we can do the ultrasound, we can do the MRI, and we can do the contrast MRI also. But until unless we get a diagnosis, we should be persistent with the patient and not leave her. And perhaps it's better to do hysterectomy in these cases.
Can I make a comment, ma'am?
Thank you, Maninder. I would. Yes, please.
Amita ma'am, are we really, like Dr. Maninder suggesting, are we have to be really that, very careful, aggressive for that matter, in terms of hysterectomy?
Aggressive,
No. I think, if I understood Maninder right, we are not going to do hysterectomy for any woman who is with the post.
No, not for any woman.
Because
It's persistent.
almost 80 to 90% of the cases, they are benign. We have all the cases. Yes. Sometimes you have the fibroid polyp suddenly bleeding there. Once she puts on weight, the estrogen goes up. But then you can't ignore those polyps. The investigations are important. But once the histopathology comes normal and she doesn't have recurrent bleeding, just one episode of recurrent bleeding also you can ignore, because you're going to again. But recurrent episodes of your bleeding, postmenopausal bleeding, with no positive findings, then that, that is the time when it probably.
And many times,
That's very, very
Rita,
rare. But let me tell you, it's very rare. Like in my experience of 35 years, I just had 2 cases with that stromal, which we have to do. Otherwise, no.
Mita ma'am, and in early phase of menopause, like can it be really that some follicles get reactivated and they have a bleed and then stop again, sleep again?
Correct. That's why we said almost 40% per annum in the first 3 years perimenopause. Where you can see because postmenopause many women put on weight, and when they put on weight too much, it's like your AUB, PCO. So I think the estrogen levels just skyrocket.
Yes, my point is that transition from perimenopause to menopause, we have to be very careful. Don't hurry up for anything. It can be just part of perimenopause period, and maybe patient instead of fixed 6 months time, you can eat maybe 6, 8 months or 9 months. Even that works, no? It cannot be like 6.
No. I understood what
Since we are
I
getting
understood what
delayed,
you're saying. It
can
is
we move
actually.
ahead in the interests of time?
Yeah. Thank you. Sorry about that.
Because this discussion can go on forever.
It's just for a postmenopausal bleeding, not for the perimenopausal
Just
bleeding.
one line, Dr. Pratik. The
Yes.
answer for postmenopausal bleeding is not hysterectomy. Don't take me wrong. This is, I'm saying 1% in cases of recurrent, not even recurrent, recurrent, where you don't know it. So that's very
That is what I was talking about. Recurrent. Don't miss it. That's all.
Thank
After
you.
menopause, 1 year of menopause.
Thank you, Maninder. Thank you, Meeta. And dear delegates, I have posted FOGSI Focus on AUB, which was released in 2021, and also FOGSI GCPR on AUB, which was released in 2024 in the chat box. Those who are interested, you can download them from the chat box. So now let's move ahead to the second session.
I just
Please
want
invite
to,
the chairpersons.
1 minute, Lakshmi,
Yeah.
I want to thank Meeta for
Yes.
excellent presentation and honoring our invitation. Thank you, Meeta.
Yes,
I hope
yes.
she's
Thank
there
you.
or she
Thank
left
you.
already.
No, I'm here. Thank you.
Thank you, Dr. Arun Arora. Thank you, Maninder. All of you. Thank you.
So with this, we come to this end of the first session, and I think so. The interaction between the chairpersons and the speakers is actually depicting the whatever the confusion is still existing in our gynecologists and all. So with this, we move on to the second session, in which we will be discussing upon the complex AUB and the guidelines. So I invite the chairpersons, Dr. Shanti Roy ma'am. She is a Padam Shri awardee 2020 and is now presently retired professor and head from PMCH Patna. The second, I welcome Shanti Roy ma'am. The second chairperson is, can I have the next CV? The second chairperson is Dr. Himanga Beswa. Sir is the president Guwahati Obs and Gynae. He's a consultant gynecologist in practicing in Guwahati. Sir is the organizing chairperson FOGSI Sexual Medicine and Cosmetology Gynae Conclave 2026. Welcome, sir. And the third chairperson for this session is Dr. Remsi Siad. Ma'am is a professor, Obs and Gynae, GMC Thrissur. She is also the secretary of Thrissur as well as secretary RCOG Kerala chapter 2023 to 25. I welcome all the three chairpersons on behalf of ICOG, and I request the chairpersons to invite the speakers to take the session forward. Thank you.
Dr. Suvarna is here. Nilima, she has logged in.
Ma'am. Yes, ma'am.
Yes.
Yeah. Please invite Dr. Suvarna. Yeah. Hemanga, you can introduce Dr. Suvarna.
Good afternoon.
Hemanga, are you with me? Please admit her.
Yes, ma'am. So Dr. Suvarna Khandilkar, she is the professor and head of the Department of Obstetrics and consultant endocrinologist and gynecologist at Bombay Hospital Institute of Medical Science in Bombay. She is the Secretary General of FOGSI, present 2025 to 27, President MOGS 2004-5. I welcome Madam. She is the Secretary General to deliver her topic.
Okay. Thank you, Hemanga, for that kind introduction. Lakshmi and Sheila and everyone in ICOG. I can see Pratik. At the outside, I want to thank all of you, and I thank all the chairpersons who have joined here, taking out time to listen to this talk. So the topic that I will share the screen. I hope I'm allowed. Yeah. Is it visible?
Coming, not yet.
Yes, ma'am. We
Yeah.
are on your thank you slide.
Can you see now? Yeah.
Thank
Okay.
you.
Okay. Shall I stop here?
No, no, please go to the first slide, madam. We are eager to listen your talk. Yeah.
Okay.
Make it full screen, please.
Yes, I will. I don't know. Yeah.
Yes, correct.
Yeah, that's right. Okay.
Slideshow pe tina, yes.
Thank you,
Perfect.
everyone. The topic that I will deal with is AUBL or fibroids and abnormal uterine bleeding. And I will focus more on the reproductive age because the treatment and post-reproductive age is simple and we have straightforward answers to that. So I will focus more on that and I'll just touch upon the definitive treatment little later. So if you see the epidemiological aspects in India, AUB affects approximately 17.9 to 19% of women of reproductive age, and there is a burden of AUBL, and almost 33% of all gynecological consultations in tertiary care center are AUB. And leiomyoma is the most common structural cause of AUB in India. Almost 46.1% of symptomatic patients have leiomyoma, and highest incidence is observed in the age group of 41 and 50. I'm sure you will agree when a patient is at the 41, 42, we really don't know how to deal with this bleeding because after menopause, the fibroid will shrink and it will perhaps not give symptoms, but she has to yet go ahead with a few years. You don't know when she will go menopausal. So whether 3 years she will go menopause because our Indian age of menopause is quite less. So 46. So maybe for 3-4 years she has to bear with this bleeding. So it's a little bit tricky problem in 41 to 45 years of age. India has a very high prevalence of hysterectomy, and uterine fibroids are the leading indication contributing to over 51% of all elective hysterectomies. Now, if you see the prevalence of hysterectomy amongst women now look at this earliest age. This is a NFHS data and the age is between 15 to 49. And you can see the highest prevalence is in Andhra Pradesh and Telangana, whereas the lowest rates of hysterectomy have been found in Assam. And we have seen that the average rate overall of India is 3.3%. So when you see a patient of abnormal uterine bleeding, as we said, 33% of all women have fibroid. But is it the cause, sole cause for abnormal uterine bleeding? There will be multiple etiologies that the patients may have. So there will be coexistence of many causes of abnormal uterine bleeding in one patient. So 20 to 30% of women with AUB have more than one potential cause, and patient with submucosal fibroid and adenomyosis would be classified as per Palm-Cohen as given here. So P0, A1 and L1. So this is how the classification goes. And the clinical implications are that AUBL is the most common diagnosis in reproductive age group women, and the treatment choice if patient has both AUBL and AUBO. Suppose you do a myomectomy. So it is how much of it was because of AUBO and how much was because of AUBL. It is little unpredictable. So you may do myomectomy, but she may still continue to have abnormal uterine bleeding. So that surgery may not be actually the right choice. So surgery for the fibroid is not likely to completely resolve the bleeding. So if a patient comes with fibroid, there is a class Palm-Cohen out of palm coin classification, FIGO leiomyoma subclassification is there of fibroid. But when a patient comes to you, there is a first phase that you have to do is identify, diagnose that she is having AUBL. So detailed history, lab investigations, imaging, you have to do and systematically rule out each category of palm coin. So in the fibroid, if you can see the subclassification of leiomyoma, you start from 0, 1, 2, 3, depending on how much of the myoma is within the endometrium, and it goes out and becomes a totally subserosal. So submucosal 100% intracavitary, 50%, less than 50%, more than 50%. So these are the categories you can see in a little more colorful picture. So again, the same categories you can see and various gradations of these myomas are there. So submucosal leiomyomas, particularly type 0 and 1, directly affect the endometrial cavity, and it increases the surface area and it impairs local mechanisms of hemostasis and contractility. So the guideline-based management of such patients for women with type 0, 1, 2 myomas presenting with heavy menstrual bleeding, first line or sequential surgical intervention is highly prioritized, especially when fertility is the concern in that age group. So the degree of intramural extension distinguishing type 1 from type 2 directly impacts the technical approach. So all the guidelines, ACOG, RCOG and FIGO suggest the same. Then the symptom triad of heavy menstrual bleeding, pelvic pressure and bulk symptoms, and reproductive dysfunction. So all the three in this age group, they are all heavy menstrual bleeding is more than 70% of symptomatic patient, and bulk symptoms are often described as heavy or bloated sensation in the lower abdomen, and infertility is also approximately 2 to 3% of the cases are even more. So the assessment of AUB is seen here as history, physical examination, labs, and imaging is the gold standard. So which is the first line of imaging? Transvaginal ultrasound. And if you are suspecting the submucosal, then the saline infusion is important, saline infusion sonography for identifying the submucosal lesion 0, 1, 2. And MRI is reserved for more complex cases, surgical planning, or differentiating it from adenomyosis or sarcoma. But believe me, sarcoma is really difficult to diagnose, and even MRI sometimes may give you sarcoma, it may not turn out to be sarcoma. It will give otherwise, and it may turn out to be a sarcoma. So both possibilities are there. And the endometrial sampling as per ACOG criteria, if you can see here, age more than 45 years or less than 45 years with risk factors, unopposed estrogen, obesity, failed medical therapy. These are the indications for endometrial sampling, and the goal is to exclude hyperplasia or malignancy before starting hormonal therapy. Now, the USG modalities for myoma evaluation, as we said, it is the transvaginal ultrasound, undisputed the first line, and the clinical value highly sensitive, more than 90% of the detection of myomas more than 5 mm is quite good for with TPS, but sometimes it may miss a small submucosal lesion. And I have faced a lot of cases where they have just given a thickened endometrium and it turned out to be a polyp, and vice versa. They said it is polyp, and when we went for a surgical removal, they said there was no polyp, it was just a thickened endometrium. So transverse abdominal ultrasound is complementary to TVS, and especially in Indian clinical landscape where bulk symptoms and large palpable masses are common, you need to go for transabdominal. And clinical value provides a panoramic view of pelvis and essential for mapping FIGO type 6, 7, and 8 myomas that may be located high in pelvis or broad ligament or beyond the focal image of the vaginal probe. Now, saline infusion sonography, as I said, only for submucosal myoma. So 3D ultrasound When you are planning for a mapping of ultrasound, it's a invaluable tool, and it is an advanced mapping for surgical planning and provides a reconstructed coronal view of the uterus, which is not possible with standard 2D ultrasound. And it is vital for measuring the myometrial mantle, that is the thickness of the remaining myometrium, which is a key safety parameter for myomectomy. Otherwise, you tend to go through and through, and you may land up in a hysterectomy. So studying of this myometrial mantle is important. Then color and power Doppler, as you can see here, it is assessment of vascularity is very important. Myomas typically show peripheral vascularity and the rim sign, and a lack of internal vascularity can suggest vascularity can suggest the degeneration, while atypical high velocity central flow may raise a suspicion for leiomyosarcoma. So I always say the dictum is that if there is a peripheral vascularity, it is more likely to be a benign. If there is a central vascularity, suspicion of malignancy is there. However, the USG cannot really definitively exclude malignancy. So these are the various differential diagnoses for uterine myomas and AUB. We have all types of AUBs, AUB-A, AUB-P, AUB-M, and simply on clinical, examination symptoms, you can very often come to a diagnosis, but you need to do certain investigations to find out. So we have other Cohen classifications like AUB-C, AUB-O, and AUB-E or I. So the medical management treatment depends upon age, childbearing aspiration, desire to conserve uterus, and severity, and all the listed factors here. And then only you plan the treatment, and the ideal medical management option must have the following parameters, and that is equal or superior efficacy, easily available, affordable, and does not affect the reproductive function, and less side effects. So various medical management options that we have. First is prostaglandin synthase inhibitor. We have been using since a long time, and mefenamic acid and NSAIDs. The success rate, however, is only 25% if used alone. Antifibrinolytic agent, tranexamic acids, they have higher success rate of 50%. And if you combine the same, the slightly higher success rate may be there. Because aromatase levels are higher with myomas, aromatase inhibitors, letrozole and anastrozole for leiomyoma treatment seem logical. And we may, what is it? The time is up.
Yes,
ma'am.
Okay. I have not touched the main important thing for the this thing. I think
You can
15
quickly,
minutes.
Suvarna, you can quickly go through what you
Yes.
want to say.
Yeah,
Please
I
go
will
through it.
need a 3-4 minutes more than what you are giving me.
Yeah, please go through it.
So the step 1 is the non-hormonal symptomatic relief. As you can see, tranexamic acid, NSAIDs, which we have talked about. The step 2 is the hormonal symptomatic control. I need not go into the details, but how all of you are using this, either combined oral contraceptives or levonorgestrel IUC, intrauterine systems. And the most important now, latest, you can say the fad is the targeted fibroid volume and HMB reduction with GnRH antagonists like relugolix, combined therapy, elagolix, and linzagolix. And relugolix is, all US FDA, India FDA approved for high or heavy menstrual bleeding, and it is comparable to leuprolide in size reduction, but earlier effect on bleeding. And US FDA is fibroid related HMB when used with add-back therapy. Now, mifepristone, I think I will skip, but there were several, studies have supported. It is the progestin antagonist which effectively reduces, it is relatively cheaper and reduces the size of endometrial leiomyoma, but disadvantage is that it causes endometrial, long-term use will cause endometrial hyperplasia. SPRMs, that is ulipristal acetate, 5 milligram, 10 milligrams, several studies have happened, and Pearl 1 to Pearl 4, Venus, and 1 to 2, and asoprisol, all these are used. However, ulipristal acetate has got also successfully reduce uterine volume and bleeding, but long-term medical management will have the liver in function abnormalities. So it was withdrawn, but now it has been reintroduced. Now, treatment of uterine fibroid with relugolix, a nice study here is showing a very effective combination therapy with relugolix, and it has shown significant reduction of all aspects of symptoms, the volume, the pain, everything. Now we go to, I'll skip a few of these trials. There's another trial, Liberty 1, Liberty 2, where relugolix combination therapy has been studied, and it is definitely effective. Even the long term of 104 weeks, it has been shown effective. So these are the results of Liberty 1 and Liberty 2 trials. And I just want to show you, I'll skip this, the the conclusion of all this evidence is that there is a definitely clinical challenge in surgical myomectomy, but relugolix combination therapy, laparoscopic myomectomy, a case series evaluating impact on surgical planes and operative outcomes. So I will want to show one thing that happens in our institute, and that is another conservative line of treatment, and that is when the medical line of treatment is not effective, then we use roll-off or we use selective arterial embolization. As you can see here, we used in one of my patients where she had a very highly vascular fibroid before the embolization on the left side, and this is significantly reduced vascularity, and the patient became better because she did not want to do any other surgical line of treatment, and it really helped her and she went happy. But it is not always everything green. Patients will come back with some recurrence after some time. So this is how you can do surgical myomectomy. On the other side you see the hysteroscopic myomectomy, and we had a nice case of laparoscopic myomectomy. And big myomas, we all know that you can remove with tissue morcellator and save the patient from a big scar. So a laparoscopic hysterectomy is definitely a preferred mode of laparoscopic myomectomy, or any other surgical approach by laparoscopy is preferred. Now these are the various guidelines and summary for uterine sparing has to be highly prioritized, and ACOG says it has to be balanced with surgery, and RCOG says patient choice driven treatment should be given. So when to proceed with surgical definitive treatment? When symptoms for symptomatic fibroids which are failed on medical or other conservative management, you have to proceed with the laparoscopic hysterectomy. And laparoscopy has definitely advantages over open, but it is not always so. There are times when open myomectomy or open hysterectomy is required, and of course it is a surgeon's choice as well as the patient's choice. So with ever advancing science and innovations, today's women can vouch, my womb shall bear fruit. It shall not be a place of pain, but it will be a place of promise. And we as doctors can declare, to preserve is to honor, to conserve is to empower. Thank you so much.
Thank you. Thank you so much, Suvarna. It was a fantastic, very, very informative talk. Hemanga, are you here? You want to comment?
Thank you, madam. It was a very wonderful talk. All the PGs will be benefited. I think,
Yes.
can we take one or two
Have I
questions,
stopped
or we
sharing?
will go to?
No, please stop share. Yeah.
Yes.
I can't see where.
Now you have done.
Yes.
You have stopped screen sharing.
Yes, please. Yeah.
Yes.
madam.
Yes. Yes,
Dr.
Resmi, please go
Nishinga.
ahead.
Yeah. A
Resmi,
very
yeah.
comprehensive and very to the point of madam session, madam. So I'm sure the participants will be benefited and very clear and precise on what to do. I mean, about the medical management, how to preserve the uterus. Thank you so much, madam.
Absolutely. And I think we don't want to have extremes of preservations. I mean, let the patient bleed in spite of doing conservative management, medical, surgical, and she comes back with repeated attacks of bleeding, then do not stop there and please go ahead and do a definitive treatment. We don't want to have an extreme of conservation. What for us, patient and patient's health is the priority. So there are some patients who directly come and they tell you we want hysterectomy. But you have to explain to them that the ever advancing science has many other options with which we can conserve uterus. Then why not? We have several medical management where several even robotics is another advance that with which we can do accurate myomectomies and other surgeries. So why not? At least try them. If they are not getting better, yes, then go ahead. But don't stop there and allow her to bleed. Go ahead and do the hysterectomy. So I think that is something which we must even teach the younger generation. Otherwise, they go to the extreme of conservation.
So, Suvarna, you are a great PG teacher. I know you can go on and on and on. Yeah, I can see Dr. Sheila Mani is here. She wants to comment and then we will proceed with the second talk. Yes, Dr. Sheila Mani, you wanted to say something? Yeah.
Everybody knows, it was so nice and forceful presentation. And thank you, Suvarna. This nice to see you on ICOG platform.
Yes, yes.
Are
I'm
anytime
so
when
busy.
Sheila and Lakshmi call me, I have to be there. I can't say no to
Yes,
you.
thank you.
So I have left all my administrative work in office and I'm
Yes.
sitting here for your scientific contribution.
Thank
Because you
you.
are a great PG teacher, Suvarna.
Oh, I
So
love
how can you
teaching.
forget teaching? I mean, you love teaching as well.
I love it. Yes, I can keep everything aside and keep on teaching for hours together.
I know that. I know that. Thank you so much for being with all
Thank
of
you.
us.
Thank you for involving.
Yeah. Resmi, please introduce our next speaker. Please show the CV slide of Dr. Sunil. Yeah.
Okay.
Can you see? Yeah.
Yeah. I have great pleasure in introducing our next speaker. One second. I think okay. Dr. Sunil E. Tamvekar. He is assistant professor in Naurosri Wadia Maternity Hospital and St. GS Medical College, Mumbai. He's an honorary consultant of Mumbai Police Hospital also and consultant in many hospitals. Management committee member of MOGS, Youth Council MOGS 22-25. And okay.
Thank you for the introduction and kind words. Let us move on to with the time constraints. To begin with, first of all, thank you for the opportunity, dear Dr. Lakshmi Shrikande Madam, and all the office bearers from ICOG, Sheila Mani Madam and Pratik Tambe sir. I wouldn't want to share my presentation. Just a second. My screen is visible, correct?
Yes, it's coming, but we can't see your talk. Yeah.
Yeah.
Yeah, it's coming. Yes, please
So
make
the
it full
topic,
screen.
yeah.
Yes, great.
Yeah,
Great.
thank you very much. So to discuss acute abnormal uterine bleeding, where we need to be knowing and at par with the emergency assessment and the management. So last 2 days we have been dealing with AUB, its pathophysiology, and the speakers have been explaining us the various problems women undergo as far as presenting with AUB and the pathophysiology behind it. Imagine at 2 a.m., a 38-year-old woman with heavy vaginal bleeding, passage of multiple clots, soakage of 7 to 8 pads, presenting at emergency with pulse 130 beats per minute and BP is 90/60. What would be your first step? So in modern times also, as far as gynec emergency is concerned, you will get a call in midnight and you should be ready with the tackling such situations. Let us discuss what is acute AUB, the rapid assessments, stabilization, initial emergency treatment, evidence-based management, and when to escalate to the surgery. FIGO has been always guiding us with updates in definitions and protocols and management of AUB. The 2018 update has been thorough, and we have been updates following it. What it did is it defined first HMB, heavy menstrual bleeding, as an excessive menstrual blood loss which interfere with women's physical, social, emotional, that is, with or without material quality of life. So this is 2018 update, which is the like main reference for my presentation. Apart from that, we have ACOG and NICE guidelines also. Later, what it did was it again subdivided the definition into acute and chronic AUB, where acute AUB, it says an episode of heavy menstrual bleeding that in the clinician's opinion requires immediate intervention to prevent further blood loss. Remember, acute AUB is a symptom, not a diagnosis. Like that way, it has been given and described chronic non-gestational AUB definitions and acute heavy menstrual bleeding, that is acute HMB. What is it? It may present in a context of existing chronic AUB or can occur in the absence of such background. Okay, so to manage and to deal with such clinical scenario, first question, and these are the first golden 5 minutes you're going to tackle and decide about what you're going to go ahead with. Is she stable? Is she having tachycardia, hypotension, having syncope, altered sensorium, or shock? Treat the patient before treating the uterus. So, pulse, blood pressure, respiratory rate, pallor, and mental status. Quickly. So, assess the stability, go ahead with the resuscitation, then identify the cause, medical therapy, and as the presentation and discussion go ahead, if we have to escalate, then there we have a high-end, top-notch, and the technical advances as a surgical therapy. Now, this is the most important slide according to me. Whenever AUB we are discussing palm coin classification, none other FIGO classification. But the message to dear, junior colleagues and physicians, I mean the clinicians, pregnancy first. So first exclude pregnancy, miscarriage, ectopics, or gestational trophoblastic diseases, then palm coin. Emergency assessment, history, examination, and investigations. So quickly, amount, duration, whether passage of clots, how much, pregnancy possibility, whether was she on anticoagulants. General examination, immediate speculum examination, and go ahead with your most important PV bimanual examination. We are relying on USG, but in emergency situation, basic clinical examination is going to rule out, half of it, the differential diagnosis. Go ahead with the investigations. So mandatory are CBC, UPT, blood group, cross matching, coagulation profile, and ultrasound. Of course, hormonal background, TSH, LFTs, endometrial samplings. As you go ahead with the DNC, when you're moving ahead with the medical, further from the medical management. As far as resuscitation is concerned, ABC approach, airway, breathing, circulation. Immediate, 2 wide bore cannulas, immediate IV crystalloids, colloids also as required, blood products, oxygen, monitor, vitals, assessment, and going ahead with the resuscitation. So how it helps? Because you're going to help her with fluid resuscitation and control of hemorrhage. So crystalloid, saline, hemolysis, blood transfusion. As far as other causes are concerned, quickly go through palm coin structure. So polyp, adenomyosis, leiomyomas, malignancies, coagulopathies, ovulatory dysfunctions, endometrial, and iatrogenic. NICE guidelines have been again helping us with last update in 2021-22 and also in 2025. On basis of which, let us discuss the actual treatment. So assessment as well as underlying cause. Medical management, again going ahead with based on etiology as well as severity of anemia, means the consequence, how much she has lost already. So maintain hemodynamic stability, correct the anemia, return to pattern of, so these are our aims. So immediate treatment followed by return to pattern of normal menstrual cycles, prevention of recurrence of this problem, and later prevent long-term consequences of unovulation, that is anemia, infertility, or for that matter, malignancy. So medical management, the goal is to stabilize the endometrium with estrogen. So this the treatment, this slide typically is for acute AUB, especially in the era gone by where estrogen was at our resort. Though we are not using estrogen as a routinely nowadays, it will provide initial hemostasis followed by progestins and endometrial stability. Typically, it is achieved later with COC also. Okay, so continuously over the period of several months, and then later withdrawal. So episodes of moderate to severe bleeding can typically be treated effectively with frequent doses of COCs. So briefly, let us go. So this slide describe moving ahead with the surgical. Okay, now what happens is your management, depending on diagnosis, going to depend on the presenting age of the women. So in adolescents, important is, of course, you know the fact that HPO axis is not developed. Yes, apart from that, coagulation coagulation disorders. So yes, in adolescents, rule out coagulation disorders first. After that, go ahead with your routine management of hormonal backup, that is HPO axis, stabilization with cyclic progesterones or COCs continuously. In perimenopause age group, you have cyclic progesterones or low dose OCPs. Reproductive age group, common ovulatory problem is there. So COCs and cyclic progestins. Just a second. I'm not able to see. 1 second. Yeah. Endometrial factors. This is little rare, and you would be able to come to the conclusion after ruling out the other problems. And then aim would be again stabilization through the hormones, progestins, OCPs, or LNG IUS. As far as immediate drugs are concerned, you are going to rely first on simple NSAIDs and tranexamic acid. So now tranexamic acid has given, backed up by enough evidence now to start immediately with adequate doses. Sometimes we make mistake of giving inadequate dosages as far as tranexamic acid is concerned. Okay, so apart from tranexamic acid, mefenamic acid, ibuprofen, naproxen sodium, alpha aminocaproic acid, tranexamic acids, then para aminomethyl benzoic acids. So, of course, tranexamic acid is going to help us with antifibrinolytic action. So, I'll just give the gist of medical management. Further going ahead, you have options of GnRH analogs. My screen is getting blocked, unfortunately. Sorry for the disturbance. Just a second. Yeah. Okay, so this is again gist we are getting. Tranexamic acid, COCs, high dose progestins, and IV estrogens. So immediately you can give 1 gram IV as a first line therapy, and then 500 mg QID. That is the correct dose, 500 mg QID. If required, we can, continuously provide even higher dosages than that as a maintenance dose of dosages of 1 gram repeatedly again. Immediately, medical combined therapy can be given as COC as well as progestin as high as 3 times daily immediately. MPA also as high as 20 mg 3 times a day, especially when estrogen is contraindicated. And of course, IV estrogen 25 mg IV as an emergency resort. But then there is a controversy regarding evidence backup for giving injection testosterone. So that option also we have. So estrogens, what you can give is conjugated equine estrogens, oral form as well as IV forms. Okay, so this was regarding progestins, various progestins. So you have MPA, depo-MPA, norethistron, etc., etc. So this is what I was talking about. So gone is the era of danazol, so which was synthetic androgens. Yes, senior, clinicians here still prefer that, and that is also a wonder drug at times for such emergency presentation. That is 200 mg danazol. So tranexamic acid, if you want to calculate the maximum dose, that is 10 mg per kg, IV 8th hourly, and per orally 1.3 gram per orally 8th hourly. Simply 500 mg QID is okay. Other things we just discussed. Indications for hospitalization: hemodynamic instability, hemoglobin concentration is less, that is anemia correction, symptomatic anemia, IV injections, and surgical intervention. Quickly, let us go through the indications for surgical. So first and foremost, what should come to your mind is immediate ablation. Means what? Immediate resection of the endometrium. That is nothing but dilatation and curettage of the endometrium. So that at times become life savior. So DNC for excessive bleeding. Okay, especially perimenopausal age group, failure of medical management, significant instrumental bleeding. So if you tried medical management, so please go ahead with DNC, and that gives advantage of endometrial sampling also to rule out malignancies or pre-malignant regions. Endometrial ablations is a next level modality where hysteroscopic ablation is possible, and it is an alternative to hysterectomy. So various forms are available, various options are available, and these are the various indications. So especially to find with a good ultrasonography, or if required higher imaging modalities, rule out uterine problems like polyps and fibroids, etc. And of course, hysteroscopy gives us options of operative resection. So these are the various contraindications. If you have advanced technology,
To interview, sir, your time
yes,
is.
so I have finished almost. So this is just to know that advanced technologies at our helm with the interventional radiology, uterine embolization, and hysterectomy would be the last resort. But as far as immediate treatment is concerned, we have discussed the immediate management. So yes, ACOG, nice recommendations, and FIGO. So tranexamic acid has been evidence-wise proven repeatedly in these guidelines. So always remember, adolescence, coagulopathy, perimenopausal, exclude malignancy, anticoagulants, multidisciplinary approach. So medical management fails mean there is a red flags, persistent hemorrhage, instability, anemia, pathology, as well as malignancy. So this is the algorithm we have gone through. So take home messages: stability, resuscitate early, exclude pregnancy, stabilize before DNC, that is most important. Medical therapy, operate selectively, consider bleeding disorders in adolescents. Endometrial sampling is must, more than 40-45. Do not underestimate acute AUB. Thank you very much.
Thank you, Sunil. It
Thank
was
you.
a
Thank you.
very informative talk with lot of practical take-home messages. Chairpersons, please comment and invite the next speaker. Anyone with me? Hemanga, Resmi? So, thank you.
Lakshmi?
Yeah, Resmi is here. Yeah.
Lakshmi, can I just make a quick comment here, Suvarna?
Yeah, please,
here?
please. Yes,
See,
Suvarna.
When I saw the next topic, I just thought I'll hang on because acute, episodes of hemorrhage are really worrisome, and we don't know that it can kill a patient. It can kill a patient, and we did see a patient like this, and I have reported that case report in my book on AUB, which of many years ago I have written that. But her hemoglobin when she came to our tertiary care center was 2 grams, and then she was shifted to ICU, and she just was shifted to our center just to die. After she was shifted to ICU, she just died. And when we went into a history, it usually caused, we think that it could be obstetric cause, but there was nothing. It was a acute hemorrhage going on for 3 to 4 months earlier, and it never stopped.
And then when she came, there was a huge episode of bleeding, and all the blood was exsanguinated. It's terrible. So such rare cases you may get to see. So never neglect, as Sunil said, never neglect any case of EUB. Thank you.
Yes, yes. Thank you,
Yes.
madam. So,
I know there is a comment in the textbook. Yes, postcoital bleeding.
yes, yes.
Yes.
Yes,
So
that is
thank
also
you, Sunil.
important cause. Yes, one person is asking if patient is on anticoagulants and present like this, how to proceed. So definitely it requires multidisciplinary approach, immediate shifting to MICU, and this is the tricky thing. We should be suspicious. Patient have being on anticoagulant presenting like this, then factor 10A level should be performed, and then it should be with the involvement of physician and hematologist uh, to go ahead with the immediate cessation of the blood loss and forming the clots.
We can do the questions in the chat box, sir. Let's
Chat
move
box.
on because they're
Yes.
already delayed.
Yes.
Thank you
Yeah.
very
Thank you
much,
very
Dr. Sir.
Thank you. Yeah.
Resmi, please invite our next speaker. Yeah. Unmute.
I have great pleasure in inviting Dr. Venugopal M., my friend and a member of our Thrissur Obstetric and Gynecology Society. He is a consultant ART specialist at Birla ARMC IVF Fertility Center and a very renowned person in infertility. Over to you, Dr. Venu, for the session on AUB.
Yeah, Dr. Venugopal, are you here? Hemanga, then you can conclude the session after his talk. Yeah.
Okay, ma'am. I just saw him a couple of minutes back.
Yeah.
He has some network
I
issues.
spoke with him also. He said, I am here only.
No, I saw him. I saw his video on this. Maybe some network
Yes,
issues, or maybe he thought he could squeeze in one OPD patient before he was done.
Let me call him because he said he will be here. Because once we start panel, then he will be stuck.
In the meantime, we have Dr. Meera Agnihotri, ma'am. Madam was the guest of honor on the first day. Thank you very much, ma'am, for joining us. It's always lovely to have you with us. Your presence and your blessings really motivate us.
Unmute करो मैडम को.
कर दिया मैंने.
Pratik, he is having network issues. Can we start with the panel then?
Yeah, I think we can
शांति
do
रॉय
it.
मैडम प्लीज आप
Shanti Roy madam is
चेयरपर्सन
also.
हैं. प्लीज कमेंट करिए सेशन के ऊपर. बाय दैट टाइम वी विल हैव हर कमेंट्स. शांति रॉय मैडम को अनम्यूट करो.
I have sent her a request.
हाँ. नहीं मैडम अनम्यूट. टेक्निकल टीम प्लीज अनम्यूट मैडम शांति रॉय मैडम को.
Send the request, ma'am.
हाँ मैडम, तीनों टॉक के ऊपर आपके एक्सपर्ट कमेंट्स चाहिए. नहीं मैडम बोल रही हैं पर
she is unable to unmute herself. I think she is speaking.
Why रे?
Venu is here.
Speaking. But you can unmute her from your side, na?
We've sent
Yeah,
her.
yes.
Yeah. Now we can hear you, Shanti madam.
मैडम आपके एक्सपर्ट कमेंट्स
Now,
चाहिए तीन
yes,
टॉक के ऊपर. हाँ.
Yes. All the lectures are very good. And the only thing I want to emphasize that now, recently, there has been a trend that the patients are not examined physically. That is bimanual examinations, speculum examinations are mostly omitted by many gynecologists. So you must emphasize the importance of pelvic examination because diagnosis can be made by pelvic examination in many of the cases. And the lectures are very nice, superb. Dr. Sunil has described the management. He has tried to describe all the management in short according to the points. And I have never met a patient of AUB in my life who died due to AU, abnormal uterine bleeding. They all were manageable and I could manage them. The most important treatment I provide to them is progesterone in heavy dose. I don't give estrogen. And
Hello.
I do give, yeah.
आप जस्ट डायल से बोल रहे हैं? मैं ना ये
हम बोल रहे
लास्ट
हैं।
ऑन कर रही हूँ
प्लीज अनम्यूट
क्योंकि
म्यूट
मेरा
करो, कौन बोल रहा
है
है?
नहीं
हाँ,
बिजनेस,
यस
और
मैडम।
आप मेरा नंबर वहां से डिलीट कीजिए।
हाँ, रॉय मैडम।
हाँ, वो हम जब भी डिसफंक्शनल एब्नॉर्मल यूट्राइन ब्लीडिंग की पेशेंट, अगर कोई पैथोलॉजी नहीं है, तो आई हैव फाउंड हेवी डोज ऑफ प्रोजेस्टेरॉन ऑलवेज यूजफुल, एंड I generally I give it 10 milligram 3 times a day. I start and then taper it according to the amount of bleeding.
Thank you, madam. Thank you for sharing your practical tips. Now let us start with Dr. Venugopal.
Let
He
me
has
thank
logged
her.
in and
Lakshmi.
Huh?
Lakshmi, let me thank Madam. Madam, thank you very much
Yes,
for
yes, please.
accepting our invitation, and we are honored to have you in our virtual AUB certificate course. Madam Shanti Roy, thank you.
Yes.
Thank you very much.
Thank you,
Dr.
Shanti Roy,
Meera
madam,
ma'am and
for
Dr. Shanti Roy ma'am.
Pranam.
accepting our invitation. Thank you.
Sabko namaste or blessings. Lots of blessings for this program.
Thank you, madam.
We are honored. We are honored, madam. Venugopal, please start.
Yes. Yeah. Thank you to the ICOG. Thanks, Lakshmi madam, Sheila madam, and Pratik. Thank you very much for giving me a chance to make this presentation. I hope my slides visible. So I'm
Yes,
speaking on a topic that is very close to my heart as a reproductive medicine specialist. It's fertility sparing management of atypical endometrial hyperplasia. I hope in the next few minutes I'll be able to dwell on this topic. This is a slightly crowded slide, but I just urge you to look at the right side of the slide just to get the classification clear, that over the years, the way in which the classification has evolved. Now there is nothing called as simple hyperplasia, complex hyperplasia with atypia. Now it has all been classified. If you find atypia, then it falls under endometrial intraepithelial neoplasia. That's the system and the modern complex. There's no subdivision into simple and complex. Architecture is not used for classification. Atypia is mandatory. That's where we are coming from. And there are three types of patients in which you can get. Those with atypical endometrial hyperplasia alone, those who have this atypical endometrial hyperplasia in a polyp, or where there is atypical endometrial hyperplasia inside a malignancy. So now when patients always want to know why this happened, that why a young lady like this, for sake of simplicity, I just put 3 points. Excess estrogen, as we see in PCOS, obesity, all related disorders. Excess energy states, insulin resistance, diabetes, and metabolic syndrome, and erratic genetic. The incidence is increasing, and why you find more and more patients with this. You have to go to the Indian context, and here you find some common facts. A common thing is delayed diagnosis due to AUB being ignored, high prevalence of obesity and PCOS. Many patients come to the infertility specialist first with PCOS rather than going to the gynecologist. Then there is cost constraints, limited access to gynecological oncologists, and often ART is delayed after complete recurrence. So when we come to a patient who's desirous of pregnancy, she has 4 concerns, or everybody has 4 concerns. Hidden cancer, will it progress, will it persist, and will it recur? So you see this, I have just made an infographic here for this. 30 to 50% of these patients will have concurrent occurrent endometrial carcinoma. Very important to understand. So before we start preserving the uterus, we have to rule out that carcinoma. 8% will progress to carcinoma if untreated. 10 to 25% will have failed to achieve complete response to whatever treatment. And then during treatment, 3 to 8% will progress, and 25 to 40% will have recurrence after complete response. So surveillance is very, very important. So whom will you try to conserve and not do a hysterectomy in this category is a young woman where you have confirmed EIN, disease confined to the endometrium, no myometrial invasion, excellent compliance, and who will understand that this is only a temporary bridge to motherhood. This is very, very, very important to talk to the patients. So automatically, if you saw that what all can happen when a patient has EIN, you know that how to proceed with this patient, how to evaluate this patient. There has to be good clinical assessment. There has to be a histological confirmation. hysteroscopic evaluation as and when necessary, image and staging, exclude high-risk features, and assess the patient's suitability for conservation. This is very important. So when you try and conserve the uterus, what are the three pillars of fertility sparing management? There are three pillars. One is the use of oral progestins like megestrol or medroxyprogesterone. Second is the use of the levonorgestrel IUS. We often say Mirena, but all options can be offered.
Venugopal,
And the
can you
third
please,
is
you can
to
switch
offer
off
a
your
combined
video.
therapy of both these together. Yeah.
Venugopal, please switch off your video. Your voice
Yes,
is breaking
madam.
in between. Yeah.
Yes. Yes, yes. Yeah, yeah. 1 minute. Is it clear now? Yeah. So now to explain, So now to explain the 4Ds as to why progestins are so popular. What do progestins do? They deny estrogen, okay? They differentiate proliferative to secretory. They destroys the abnormal cells, and then they diminish the endometrium or cause thin inactive endometrium or cause endometrial atrophy. This is how it works. Now the commonest medicine that is used is megestrol. Everybody asks how. I think this slide summarizes that one. Standard dose 160 milligram per day. Obesity, slow response 320 milligrams per day. Response assessment after 6 months. No response, then recommend hysterectomy. So these are the different guidelines. I just summed up the different guidelines of the use of for the use of megestrol. So overall, the consensus is continuous use is preferred. There's a small difference between the biopsy 3 months or 6 months. Why not use medroxyprogesterone? You can use medroxyprogesterone, but look at the dose. 400 to 600 milligrams per day. So when you use megestrol, you have lower pill burden, higher potency with megestrol. That's why megestrol is a more favored drug. Can't you use the other medicines? There are a lot of trials which have used other medicines like dydrogesterone, depomedroxyprogesterone, micronized progesterone, and dynogest, but most of them are experimental, limited, or sparse, or weak in their mode of action and with the available evidence. This is very important to understand in this. What about LNG IUS? Again, your Mirena insertion after hysteroscopy DNC, review biopsy after 3 to 6 months, continue therapy if it's persistent. After complete remission, attempt ART or whatever treatment you want to do. And after family completion, you then advise for a hysterectomy. Again, major guidelines I have compared regarding the use of Mirena. The differences between the sampling, some say 3 months, some say 6 months, and then some advise continuous sampling. So by and large, but Mirena is now being more and more preferred. So if somebody asks, is Mirena better or is an oral medicine better? See, this is the latest study I picked up from 2024. It says and talks more in favor of the use of the intrauterine device for the faster response, for the fewer failures, better tolerability, ideal for obese women. I told you obese women with PCOS are more there. So why this might be superior? Higher local drug concentration, minimum systemic metabolism, continuous exposure, better compliance, less weight gain. So you can see the array of benefits that Mirena is or the LNG IUS seems to be offering. Now, when this patient becomes, after this treatment, you've conserved the uterus, what are you expecting? You expect a pregnancy rate of around 58.4%, which is actually pretty good. Live birth rate of around 48.7%, again, which is good. IVF pregnancy, slightly better rates than waiting for natural conception. And, so that point has to be understood. I just summarized the latest study regarding the various progestin strategies. All progestin regimens are effective. LNG IUS remains superior to oral therapy or seems superior. Combination therapy also will perform well. Obesity adversely affects outcomes. So these are few, long-term surveillance is essential. Few takeaways that you should always remember. Now, when we talk about EIN, you should remember that we are doing histopathology now, but there will be a time when molecular diagnostics will come. Already it is there. It is not the benchmark, but there are few things you need to know in immunohistochemistry like pole mutations, MMR deficiency, deficiency, P3, P53 abnormality, because they are going to filter out the excellent candidates who require surveillance, and where fertility sparing is generally discouraged. That's where the things are headed. I looked at the latest systematic review and meta-analysis regarding this subject, and it says that overall efficacy, main findings, progesterone-based is effective for both EIN and as well as for EC. Complete response can be expected in 78 to 80%. Pregnancy outcomes are good, but we have to have long-term surveillance because recurrence is there. 22 to 33% recurrence is going to be there. New drugs like metformin and GnRH agonist combinations are being tried, but they are not yet the benchmark. So if somebody asks me that crystal ball prediction, that now we do histopathology, we do hysteroscopy, then where are we headed to in the next, say, 3 or 4 years? And then this is the way we would put it. Definitely molecular classification is coming. It's coming in a big way. It's going to be LNG-IUS, which is becoming in the preferred first line of therapy in most of the patients. Surprisingly, GLP-1 agonists are becoming routine adjuncts in obese patients. You will have, especially in this case, AI models to predict individual complete remission and recurrence risk. AI models will come into this in a big way because here our screening has to be very accurate and we have to choose the right patients. And then other things like microbiome targeted therapies and genes targeted therapies, they are on their way. I just wanted to complete my talk with a couple of cases that we have dealt with. It should not look like as though it's purely theoretical. We encounter as infertility specialists these patients more frequently than we used to do, say, 10 or 15 years ago. That is because of the increased incidence of this combination of PCOS, obesity. So here is a patient, 28 years old, married 5 years, her BMI was normal. At 13 years, she had thyroidectomy, then HPR showed adenomatous hyperplasia. She conceived once and miscarried within 6 months. Then, she had 11 ovulation induction cycles. And ultrasound showed a fundal polyp of around 10 millimeters. So we did a laparoscopy, and then the fundus showed polypoid structures with excrescences. Polypectomy was done, adhesiolysis was done, but the histopathology came as atypical endometrial hyperplasia. MRI we did as a follow-up, which was normal. That time we referred the patient to a nearby cancer center where DNC done. They gave migestrol and that dose prescribed. After that, patient continued treatment for 3 months. We advised ART, but she opted for IUI. 2 cycles failed. Subsequently, she underwent ART. When endometrial sampling was done, she had a successful pregnancy outcome and delivered a child, 2.3 kilograms. But unfortunately, again, patient is not regular with follow-up. Second case, again, primary infertility. So by then we had done a diagnostic hysteroscopy, laparoscopy. At the time of OPU, we just did a routine, curettage. She was hyperstimulated, so we're going to freeze the embryos, which showed a polyp with atypical endometrial hyperplasia. We put in a Mirena LNG-IUS, repeat biopsy after 6 months, no atypia. Then we did a transfer. She conceived. She had a preterm delivery at 28 weeks. Baby went out of the NICU, is now doing well, but patient just wants to transfer remaining frozen embryos after 2 years. She wants another child. So this is another case we advise surveillance. We have continued putting her Mirena and we have advised follow-up for the patient. So thank you very much for a patient hearing. I'm sorry that the quality of video was not up to expectation, but I hope I did justice to the time I give the talk.
Yeah,
Thank you.
we could hear you, Venugopal. We could hear you. And it was a fantastic talk with lot of take-home messages because I purposefully gave you in a typical hyperplasia only because otherwise it's really easy to manage in otherwise AUB cases. But we really should know how to manage fertility in atypical endometrial hyperplasia, in typical endometrial hyperplasia because everybody gets panic that now it is atypical, the risk of malignancy is 30 to 50%, and they discourage patients.
Lakshmi ma'am, we lost you. Ma'am, you're on mute.
Yeah, so you gave a very good take-home message that even if she is having atypical hyperplasia, where risk of malignancy is 30 to 50%, But after due counseling with negative biopsies, you can counsel her and you can take her for fertility treatment. So thank you for giving that clear take-home message. Yes, chairpersons. Yes. Pratik would like to say something. I know he is also IVF person.
No, I think this was a very good, engaging discussion. We've had three fantastic talks. All of them were evidence-based. They were all delivered by experts in the field. And I think this is something which is the core principle of what all of us practicing OBGYNs need to understand in today's world. That it has to be a personalized approach. One size never fits all. It has to be algorithmic. And there are patients in metro cities who will sit and Google in front of you. Now they don't even wait to go outside the chamber to check whether the doctor has said something right and whether it is updated or not. Therefore, it's important for us to be updated, be nuanced, be personalized, and ensure that the right message goes through to the couple.
Thank you. Thank you. Our moderators and experts have already logged in. So let us start with our panel discussion. Meeta, please invite the moderators and experts.
Thank you so much, ma'am. With this, we come to the final session of the third day of this AUB certified course. It is my honor to invite the moderators of this interactive session, and the topic will be perimenopausal AUB. How aggressive should we be? When to suspect malignancy? Fertility sparing choices in AUB. And I invite the moderators, Dr. Girja Wagh. Ma'am is a professor and head Department of Obs and Gynae at BVDTUMC, Pune. She is also the director of Primrosa Wellness and Care. She is a consultant at Bharti Primrose Wellness Center. Welcome, ma'am. With ma'am, Dr. Girja, we have Dr. Hafizur Rahman. Sir is a professor and head as SNMH Sarsa, India. Sir is also the GC Governing Council member of ICOG from 2021 to 2025. Sir is former head of Obs and Gynae, AIMS Kalyani, and unit chief at SMIS and SMU Gangtok. Welcome, sir. And I hand over for this session. The experts are who need no introduction, and that is Meera Agnihotri, ma'am. She is Professor Emeritus, and I don't think so. This small CV can really do justice to her. The name is itself more than sufficient. Welcome, Meera ma'am, to this ICOG panel as an expert. And the second expert is also somebody, matlab, it is very difficult to introduce these people. Reshma Pai Dhillon ma'am, who has had an, I think so, the
Past
leadership for
president of
each and
every
every,
organization.
yes, sir, for each and every organization of FOGSI. So they are the experts who need no introduction. So welcome, Meera ma'am and Reshma ma'am. And I invite the moderators to please invite their panelists for the session.
Hafizur, please.
Yes, ma'am.
Giriza is held up in one emergency. She will try to log in as early as possible. Meanwhile, Hafizur will manage the panel. Yes, Hafizur.
Yeah, thank you so much, Lakshmi ma'am, and ICOG chairperson Sheila Mane ma'am, Dr. Pratik Tambe. I'm grateful for giving me this opportunity, madam, especially Lakshmi madam. And Dr. Giriza Wagh madam is promised to join back once she gets free from her emergency. So as Dr. Meeta said, we have so many greats in this, Madam Meera ma'am and Rishma madam. And we had so many great talks actually rather by the experts, and it's very been difficult to again to have the discussion going on. But what we would like to more often like how the experiences and a few cases maybe would like to concentrate on them more on clinical experiences as well as what the expert says. Actually, we have great.
We will just flash their slides, Hafizur, and you can just call them by name.
Yeah, we have the expert panelist, Dr. Rajashi Sengupta. So, madam is professor and head at Datta Medical College and at Nagpur. So, welcome, Dr. Rajashi.
Next.
Yeah. Then we have Dr. Tarini Taneja, madam. Madam is gynec consultant and laparoscopic IVF specialist, Taneja Hospital. Welcome. Tarini Taneja, ma'am. Then we have Dr. Monica Umbardans. She is nursing home, her fertility center. Welcome, Dr. Manika.
Next.
And we have Dr. Sunita Wadhwani. Madam is President, Ratlam Obstetrics and Gynecology Society and Director Consultant at Ratlam Hospital. We have Dr. Sasibala Bonsale. Madam is Senior
From
Obstetrician.
Gwalior. Yeah, she's GCM and from Gwalior. Yes.
Welcome, ma'am, Dr. Sasibala, madam. And we have Dr. Anubha Vidyarthi,
She
madam.
is from Gaya. She has not sent her CV. She is from Gaya. Yeah.
Then we have Dr. Sundar Narayan. Welcome, sir. Sir is endoscopic surgeon and fertility specialist.
From Nagarkoil. Yeah.
Then Dr. Indrani Roy. Dr. Indrani Roy is a DNB teacher and senior consultant HOD at obstetrics and gynecology at Nazareth Hospital, Shillong. Welcome, Indrani. Next. Then we have Sonal madam. Madam is consultant gynec and ART specialist, Ahmedabad. Then we have
Welcome, Sonal. Huh?
We have Suman Sinha madam.
Yes.
Welcome, ma'am. So we'll welcome all the expert panelists. And I would like to go to the directly.
Tech team, as soon as Dr. Girija Wag joins, please.
Yes. Yeah, yes,
pay
ma'am.
attention.
I would request, ma'am, and because many cases for Giza ma'am as well. I'll just a few seconds.
Welcome, Dr. Hapijo, as a co-moderator.
Thank you so much, ma'am.
Girija is not there. What happened?
Girija, he is held up in emergency. She said she will log in at the earliest. Yes, please, Hafizur, start.
Yes, ma'am.
Welcome, Reshma. Nice to see you on ICOG platform.
Hi.
Why? क्या faculty बुलाई आज लक्ष्मी ने? बाप रे.
People inviting us.
सबने हाँ बोला. I am on.
Welcome,
No
Reshma
cannot be said
ma'am.
to all of you all, you know that. So
I
here
am honored.
I'm not
We are
Hafizur,
honored. Dr. Reshma is there.
Yes,
कोई
ma'am.
problem है? Yes.
So thank you so much, ma'am. We have a detail on
Start with the cases, yeah.
system and as well as sperm coin classification. I'd go straightly with from the panelist opinion, and then we'll have the expert opinion on the practical points and the experts.
Great.
Experts on take on this. So we have this patient, 44-year-old lady, para 3L3. Patient presented with mild dysmenorrhea along with occasional increased menstrual bleeding. So it was not regular. It is sometimes, she said, as the patient. Sorry. So mild, she has symptoms is gradually worsening. She complained, and there was a transvaginal ultrasonography she came with, which showed a 6 centimeter well-defined uterine leiomyoma, that is FIGO type 4-5. So it's very simple history, and like what will be the, I'd like to Rajasi madam, Tarini madam, and Monica madam. That is very simple history at this age group, how the perimenopausal age group, how aggressive will be like in evaluating or in the management. Dr. Rajasi madam, are you there?
Sir, can I take up the question, please?
Yeah, sure.
Yeah. Sir, because she's 44 years and para 3 living 3 and she's completed her family, the clinical history that she gave is worsening menstrual pain and increased amount of bleeding. So the first we will do a routine lab investigations like a complete blood count, a BT-CT, PT-INR, and her thyroid profile as well. I also wanted to know regarding whether she is obese, she's having hypertension, and she's having diabetes, so that I can rule out the other important risk factors associated with AUB. Once an ultrasound shows that there is a 6 centimeter well-defined uterine leiomyoma and the bleeding is not controlled, I would ask her to get a physician fitness done. And if the leiomyoma is not indenting into the uterine canal and there are no probable risk factors and this is probably benign, I would counsel her for a Mirena, that is intrauterine device. But if the bleeding is not very controlled and she is keen on getting a hysterectomy, after appropriate counseling of the available medical methods, I would go ahead with hysterectomy if she's very keen on it, providing that she has be understood all the medical methods also.
Yeah.
Can I add, Dr. Hafiz? Can I add?
Yes.
Because
Yes, ma'am.
you told, because she has done, I'm agreed with Dr. Monica, but as she has the fibroid, so my question raises in mind, is the bleeding severe enough to cause anemia or vital instability? So she needs the
She's everywhere stable, madam.
urgent investigation or management. And if the fibroid responsible for symptoms, or could there be adenomyosis coexist? Or is there any risk factors for endometrial like carcinoma, or what is the appropriate next step? She has already told, like physical examination, then pelvic. I would like to see if there are any pressure symptoms. Then laboratory, definitely CBC, ferritin, TSH, and pregnancy test if any suspicion. And then endometrial assessment has to be done in every perimenopausal bleeding because she is 40 years, has AUB, so endometrial sampling has to be done. The first office pupil biopsy to be taken out. If there is any abnormality in the endometrium, I would like to do hysteroscopic guided biopsy if endometrium is abnormal. And for the malignancy, maybe likely there. So for the risk is low but cannot be ignored. Red flags are obesity, diabetes, chronic like anovulation, and ET also there. So intramenstrual bleeding. So therefore, rule out the endometrial pathology before proceeding to definite treatment. Definitely, the treatment is like a medical treatment by counsel. We can give the like LNG or tranexamic acid, NSAID, and continuous progestin. According the treatment has to be individualized. And if the symptoms are slightly significant, then family is completed. We can further proceed for the total like hysterectomy by counseling, and fertility preserving option in this patient
if we
doesn't.
consider at this
Yeah.
age when we
Not
can have, because the patient has very mild symptoms,
mild.
when you can consider for expectant management or
Expectant
something.
management.
Can I add
Okay.
something?
So,
Can I add to this? Hafizur, can I add something?
Yes, yes, ma'am.
Yeah.
Expectant management, because
Yeah,
many
expectant
times the
management.
patient at 44 are not ready to do surgery or
Yeah. Rightly
for
said,
many of us-
Dr. Taneja and Dr. Monica. But
Yes.
here I would like to add the new latest treatment,
Yes,
that is GnRH analog. It is safe if you give it. You can give it for 6 months and see the result. If patient is improving, then it's fine. Otherwise, if patient has no improvement or size of the fibroid doesn't decreases, then we can think something aggressive.
Ma'am,
But
what is
can I
what
add
is the
some?
only criteria we'll have for GnRH analogs?
What is the criteria?
Yeah, that
Because
means I want to mean
she's having severe pain, you said, no?
no, it's very mild symptoms because
Okay,
that's why I'm
mild
telling when we, ma'am, I just want to when we can put the patient on expectant management and when we want to have some aggressive management.
Hello?
If
Can
you
I
can
add
put-
something? Expectant management.
Yeah, expectant management. You can say what are the criteria at this age group we see, and we can think this patient can go on expectant management.
Can I add something?
Yes.
Hello?
Yes.
Yes, ma'am.
I just wanted to say one thing, that if the fibroid is large, I would usually go for LDH test in these cases. So, rule out the malignancy first, because sometimes sarcoma can be there. And then we do, we see whether this fibroid is growing in size or not after repeated sonography. Otherwise, symptomatic management during periods for a dysmenorrhea and menorrhagia will do if patient is keen to preserve a uterus.
So
But
at 40
usually in large fibroid, I do go for LDH to rule out, sarcomatous changes.
Large means, ma'am, what is the large size at
6
44?
centimeter, I would consider large. More than 6 centimeter, we consider it large.
Okay.
Yeah. Hafizur, I just wanted to add one thing.
Yes.
Just one thing. I think
Yes,
I will
ma'am.
first do a clinical bimanual examination to see what is the size of the uterus. So
Yes.
if, yeah, to see whether the uterus is palpable or not.
that will also decide my course of management. So anything which is palpable above the uterus, not 12 weeks, 14 weeks, even sometimes a 6 centimeter fibroid, it might be just like, 8 to 10 week size when you do a bimanual examination per se. But if you see like, it is more than 12 to 14 weeks, then we will think of actually what should be our course of management. But
Yes,
most
ma'am.
likely here, expected management should be because her symptoms are very mild. She doesn't have any heavy menstrual bleeding. So it should be an expectant management.
Yeah. So what
Very,
is there?
very truly.
Yes, Dr. Asi.
Actually, I would like to concur with Dr. Roy, madam, that bimanual palpation has to be done because we need to know the location of that fibroid. And if it is causing pressure symptoms with that size, then those symptoms need to be alleviated rather
Yeah.
than only
Okay.
deciding on the size of the fibroid, one particular criteria for expectant management.
Yeah. Thank you so
And
much.
of course, I think
the
at that age, endometrial sampling is essential.
all the criteria, actually, the FOGSI guideline, ACOG guideline, and SOGSC, that is when there is absence of severe symptoms. That means it's the severe symptoms and in the perimenopausal age group. If the patient is close to menopause, no suspected malignancy as we have seen endometrial evaluation. If the patient is stable hemoglobin and on normal endometrial evaluation, what we have got, then we can put the patient on an expected management or only symptomatic and medical management. Now, relative exclusion and those are monitoring triggers are like if the bulk of the uterus, as like Dr. Indraniba said, that is the uterus size is significant. If there is pressure symptoms, so we need to go evaluation again the patient, the symptoms, whether she's only telling on bleeding and if there is rapid growth. Rishma ma'am, anything would like to say on that? It's expert, I think, because the size many time matters or we when to put, because there has been always some type of disagreements or there when the asymptomatic fibroids are there.
Thank you. I think you summarized it very well. Basically, I don't think there is any perfect solution, but I would definitely favor conservative management.
Yes,
particularly having proven that there is no endometrial hyperplasia, atypical hyperplasia, or precancer cancer possibilities. Definitely favor conservative management. And since I don't even believe that this fibroid is causing the menorrhagia for sure. That is incidentally found there, may contribute a little bit to some uterine, pain or something during the period, some contractions kind of pain. But I believe this could be just hormonal issues causing perimenopausal hormonal issues causing the heavy bleeding. So I would favor really putting in a hysteroscope, checking everything, biopsying, and putting in a Mirena at the same sitting. It will help everything, including the fibroid, from progressing. Of course, we can do GnRH agonist, antagonist, but I'm not in favor of that because the girl is only 44. How long are you going to give her that menopause at this point in time? So I think a Mirena with hardly any side effects, with long-term benefits, would really be my number one choice. I very rarely do hysterectomies unless it's cancer. So I'm not in favor of that at all, unless you really prove that the fibroid is the reason behind all her problems, which is extremely unlikely in this case.
Thank you so much, ma'am, for your expert opinion. I think that will put most of the points in place. Now, this is another patient. That is a patient is 40-year-old lady, wife of a physician, married for 3 years, nulli gravida, and they were trying for a pregnancy. The woman complained of heavy menstrual bleeding for 8 months, 26 day in cycle, bleeding 7 to 9 days with clots. She's trying for pregnancy for 24 months, tracking ovulation because they have been in belief that if they have been able to conceive, their problem will be solved. But subsequently, the one ultrasonography, they found out too. So initially, the patient was trying. Then once the evaluation of infertility, it was shown a fibroid 4.3 into 4.1 centimeter on the posterior uterine wall. That is FIGO type 1. Now, what further physical and diagnostic workup it is need to be done? Sunita madam, Dr. Shashibala, because this is a patient 40-year-old perimenopausal woman, they have been very actively trying.
Yes. So here is the patient with AUB. She's got infertility and she's underwent some mucous fibroid, incomplete hysteroscopy. They said no, it was not done properly, and we would like to go for, again, we'll have a simple clinical examination, her BMI, thyroid, per abdomen, per vagina. We'll see again the size and the mobility. That is very important. Tenderness, any adnexal problems, or there is some nodularity, that all. After that, now since she's infertile, what is more important is we have to do her infertility workup. So first thing what we do for her, go for her ovarian reserve. We see for AMH and AFC. So that is very important. And tubal patency, again, you have to do by hysterosalpingography. And of course, semen analysis, they have mentioned that semen analysis was, I think, normal. I think somewhere it was written, humans, normal semen analysis. So then again, once we have done the evaluation of AUB and thyroid profile, then we have to do, it is type 1. They have mentioned the FIGO type 1 fibroid is there. So intracavitary, how much component is there? That again we have to see.
Ma'am,
How much is the
sorry,
distance?
ma'am,
Yes,
sorry
yes.
to, she is having already an ultrasound says the type 1 fibroid. Would you like to do an hysterosalpingography or something else?
Ultrasound says, can you share the question?
Myomectomy.
Yeah, she has
Hysteroscopic myomectomy.
Myomectomy.
Yeah, ideal indication is that FIGO type 0, type 1. So that is,
so
so
for
hysteroscopic myomectomy would be
yeah,
ideal.
hysteroscopic myomectomy, madam, would you like to do more any investigation for evaluating the fibroid? That's what I wanted to mean.
Saline infusion sonography.
Yes.
Tubal patency.
Saline infusion.
Saline
Yes.
infusion sonography should be done.
Correct. Saline infusion sonography is an
So
option.
that we know the outline of the fibroid and we know where we have to, the operative surgery has to be planned accordingly.
Okay. So once,
Actually,
madam, the
we should
patient. Yes, please.
Yes.
We should remember that after doing our hysteroscopic myomectomy and checking for the tubal patency also, we need to start her infertility workup because these patients generally have poor implantation rates with the distortion of the cavity due to the fibroid, the type 1 fibroid. So we will have to be mindful when we are managing her infertility part and be slightly more aggressive in addressing that issue.
Yeah. Thank you so much. So what is there the one gynecologist is seeing her, because this was a patient came after and a second attempt to me. The patient underwent a hysteroscopic myomectomy by a local gynecologist, which was incomplete. The doctor that time said it was incomplete. So the concerned gynecologist advised for a second sitting myomectomy after 2 months. Now just I would like to say, anything hysteroscopic myomectomy, because this has been there. Whether has been the decision, because here we have mentioned type, that was the reason I was asking whether to evaluate further investigation or whether we are going for a saline infusion sonography or we would like to do an MRI, because this was a failed attempt. So when to select a patient for hysteroscopic myomectomy and when not? Anyone can this.
Actually, in this case, I would like to do other further investigation. Definitely, MRI already has been done. So I would like to do hysteroscopy, maybe
MRI is
CNT.
not yet done, madam. Only the
MRI
ultrasound.
is not done. Okay,
Yeah,
okay.
the
So
ultrasound
MRI
based
has to be done to exclude, to know the exact position of the whatever is remnant. Moreover, if is there any other co-pathology, maybe the adenoma, something else is there. So to now decide whether the second look hysteroscopy will benefit the patient or not. If it is no other pathology except the remnant residual has been left, then definitely after 6 or 8 weeks we have to remove that. That's a residual myoma, and look for the other investigation. For the female, we have already done SSC, and the for the male infertility semen examination we have to see, and the diagnostic hysteroscopic see and treat. Then we can advise the patient for the IVF planning, or it may be the individualized
Thank you
disease.
so much, ma'am. So his submucosal location, that is type 0, 1, 2, or sometimes maybe considered in 3. Favorable size, that is the size said 4 to 5 centimeters, smaller than 4 to 5 centimeters. So it was
Yes.
between 4 to 5. This patient, an adequate myometrial margin. So there must be a safe distance between the deepest edge of the fibroid and the outer serosa to preserve uterine function. That is, we have to need. So hysteroscopic myomectomy, when not to consider, when this inappropriate fibroids type, the fibroid do not protrude into the cavity, large size fibroid,
Deep.
more than 4 to 5 centimeters.
Yes.
Law-free myometrial margin, that margin is said to be if it is less than 2 millimeter from the deepest edge of the fibroid to the serosa. If it is less than 2 millimeter, then may not be a good idea to do hysteroscopic myomectomy. If the cavity is severely obliteration, that is also a relative contraindication, and inability to dilate the cervix. Now coming back to this patient, what was this? Before going for second sitting myomectomy, the husband, being a doctor himself, done a MRI which showed low signal intensity lesion 4 centimeter into 4 centimeter, along with small endometriotic cyst in the right ovary measuring 3. So this the patient husband did himself, getting advice from somebody else. So what should be the next approach?
So since the patient is of primary infertility, we are more concerned about the ovarian reserve of the patient. If we, according to Ishre, there is no need of like touching this endometria that is around 3 centimeter. So we should focus more on the ovarian reserve. If we do the surgery, so more follicle will be lost and AMH will be, lower down. And then definitely the chances of IVF success will be also low. So I would not like to touch. If there is any difficulty we see in aspirating the oocyte, only then we can think of removing, otherwise not at all.
No, ma'am, we need to remove the fibroid because the fibroid is
No,
still
no,
there.
I'm saying
The
for the
endometriotic
I'm talking
cyst.
about right now is the
I
symptom of the
am
patient, which is
talking about the endometrioma, not the fibroid. Fibroid has to be
Sir,
removed.
Sir, we need to reassess the AMH and the antral follicle counts, the number of follicles that are remaining. And if we proceed with the hysteroscopic myomectomy and her antral follicle count is low, then we could give her Lupride depot or GnRH injections, the agonist injections for 2 to 3 cycles. That would also subside the endometrioma size, and it would we can then directly take her up for an IVF cycle if her AMH is low.
But
if
for
there is
this
no
situation,
significant
we
pain,
should definitely go ahead with and do the hysteroscopic
myomectomy. That is the
hysteroscopic
fourth.
myomectomy
That is the
followed by
necessary thing.
depot for endometrioma.
Okay.
Myomectomy is a must, sir. Because
Yeah,
we cannot
thank you
yes.
so much.
Yes, sir.
I think I would like to again link back to experts for on points. Rishma ma'am, Meera ma'am, the patient still having fibroid more in the same size because we did not assess the tubal assessment also. So everyone is telling hysteroscopy, myomectomy, anything you would like to suggest that is better approach.
Madam is muted.
Ma'am.
Unmute, madam. She did not listen.
Ma'am, you are there?
Technical team, please unmute Agnihotri madam. Hello.
Yes, ma'am. I sent the request, ma'am.
हाँ मैडम प्लीज आप अपने एंड से अनम्यूट करिए अग्निहोत्री मैडम. मैडम फोन पे बात कर रही हैं.
लक्ष्मी मैडम आप बताओ.
Okay.
Agnihotri madam, please unmute yourself.
Thank you so much, ma'am. What is my intake in this situation is the patient.
She's unmute. Yes. Hafizul, yeah.
Please excuse me for.
Yes, madam.
You are
please.
audible, ma'am.
Please excuse me for 5 minutes. I'll be back in 5 minutes.
Okay. Thank you so much.
Okay.
Then Dr. Hafizul can sing.
Yes.
I'll be back in 5 minutes.
Rishma ho ki na? Rishma?
Madam,
Grishma was having one
the
meeting.
message Thanak is joining some other meeting.
Yes, yes, ma'am. So what is this? Since the first myomectomy, hysteroscopic myomectomy is not has been so successful, the second one is also going to be like a difficult one for this patient. What is I feel this hysterolaparoscopic myomectomy? That means we need to have a hysteroscopic as well as laparoscopic myomectomy, where we can have the like look of the cyst as well as tubal patency test as well. Any difference in opinion in that can? But that is the also.
Excellent.
That is
No
That's the
difference.
best approach.
Best.
That should be the
Thank you, ma'am.
And
So,
sir, may I add
be
just
more
one
concerned
thing?
towards the symptom of the patient, which is increased bleeding of the patient, rather than thinking about the infertility factor.
yes, ma'am. Especially the first physician has only tried the hysteroscopic. It has been in this type of patient. It is always better you please have a hysteroscopic as well as laparoscopic approach at the same time, because you'll be in a high pressure to finish the surgery in second sitting, and it is always safer, as I say, margin of the fibroid to look half from the both in and complete the myomectomy.
Sir,
Now we'll
let
have
me
to
just add some one
yes,
thing
madam.
that practically we have seen that if there is a large fibroid, instead of going through hysteroscopy, if the thickness of serosa
Yes, ma'am.
is less than 5 mm, I would rather go for laparoscopic only,
Laparoscopic.
not
That's
2
what we
mm
said,
in
ma'am.
this. When
You
there is a
can go
large
both.
fibroid,
So
it
it
is
is
better to keep
as
that
well as
margin at 5 mm and not 2 mm.
yes, ma'am. That's what we said. It is better to go approach from the both in if your fibroid is large. Now we'll go to the third case. 38-year-old woman married for 8 years, presented with increased flow during in our most of the cycles. She has been trying for a baby from last 7 years. She was already operated for a large endometriotic cyst. Transvaginal ultrasonography, uterus bulky with homogeneous myometrium. ET is 6.5 mm. Endometrioma is again 5 into 5.5 centimeter. LH FSH is normal, TSH is normal, TMH is 1.1, and semen is normal. So it's more of a like, do we manage most of the time? So how to manage these patients, because she is infertile 38 years.
So basically, she is has an adenomyoma, right? You said homogeneous
endometrioma,
myometrioma.
madam. She has
Only
endometrioma.
endometrioma.
Only
Adenomyoma is not there.
And already she had been operated for a large endometriotic cyst.
But does she have AUB in this case?
Yeah, madam.
Only
she has
increased
presented
flow.
it increased flow in
So
her
then
most
I
of
think, yes, we can induce her this patient for her infertility
because we need
treatment.
to manage in the both. Yes, ma'am.
Just taking care of her
Long-standing.
menorrhagia during periods with tranexamic acid would also do, because we cannot use the LNG IUS in these patients. We have to induce this. Only thing is we can use GnRH agonist as a, if we are directly going for ART, then we can use GnRH agonist one dose and then induce her instead of touching the endometrioma. That is what I.
First, we have to decide is it the second stage of endometriosis or stage 3 and 4, because
The
she
recurrent.
already has been operated for 8 centimeter endometrioma, and now she is having the homogeneous and bulky uterus. So we have to look and differentiate between first, second stage, or third or fourth.
For this patient, like, second surgery is a strict no. First thing, we just take care of her heavy menstrual bleeding and then concentrate on her infertility to give her a baby first, which whatever.
Yes, ma'am. Yeah,
that
that's
is
the
the
one.
idea.
That is
Worried about the baby first. So
you
That
need
is
to have a
already low.
conservative.
For IVF.
See,
conservative
Shire
approach for the
guidelines, yes, they discourage
conservative
this
approach for the
operative.
menstrual bleeding and concentrate on that. So that's what I want to
Yes.
wanted to mean. It's not
I
already
agree.
on jumping for.
Frankly, looking at her age and history of endometriosis and this, there must be adhesions because of previous surgery. I would rather advise her to directly go for IVF only. This
IVF,
patient,
that's it.
yes.
Yes, ma'am. So we need to take conservative management of the AUB and concentrate on her going
Yes.
for an
So treat menorrhagia with tranexamic,
yes,
give her
madam. That's what I
GnRH
do.
and
It's
then,
a conservative approach for the
Yes.
AUB. And so this is a case of 46-year-old woman presented with intermenstrual bleeding. History, that is last menstrual period ended 10 days ago. That is means what I said, intermenstrual bleeding. Prior to this episodes, her cycles are regular, though she notes there has been light intermenstrual spotting all over from the last 6 months. gynecological and obstetric history. She's sexually active with a monogamous partner, but she has not had yet a baby. So past medical and surgical history is nothing. Any significant vitals are normal. On pelvic examination, she had a enlarged globular uterus with blood visualized at the cervical os. So this is the only finding, that is, yes, she has been in relationship, but she doesn't have a kid, and she presented with intermenstrual bleeding. So what is the probable diagnosis and how to approach in this situation with a 46-year-old lady who has not yet have a baby?
She
Yes.
might have a cervical
It could be a
pathology.
polyp. It could be a polyp.
So we have to work up clinically, then via TVS, endometrial sampling,
TVS
everything. So
and
clinically, we have to look for the speculum examination for any cervical pathology or assessment. And if pap smear is not has been there recently, then we can also advise pap smear for this patient. And in for the TVS, during TVS, we have to look for the endometrial thickness, and if there any focal lesion, maybe DD, we have to look for the polyp or fibroid, and if ET is thick or whatever, if it is not thick for in this age, we have to do the endometrial biopsy. First office biopsy, people, and then if it is abnormal, then we have to do the histoscopic guided biopsy in this case. Then the differential, yeah.
What is the situation?
In this situation, the first foremost thing should be the
What are the
cervical
things can
pathology
have
should
the
be looked
from the
into.
if the ultrasonography says it's enlarged globular uterus,
Yeah.
so I would like to mean
Globular
intermenstrual bleeding.
diagnosis.
Can it be an adenomyosis?
Then,
Yes.
Adenomyosis is the probable diagnosis.
Yeah,
under palm
adenomyosis.
point, we have to yeah.
So what
So
are the
maybe the
investigation, madam, will be there for a rule out the adenomyosis as well as we say endometrial polyp or anything?
a transvaginal sonography primarily.
Transvaginal sonography.
TVS is the
thorough
gold
filtering
standard.
good enough.
And the gold standard would be MRI of the.
If any doubt, or MRI can be
Like there
done.
is blood visualized at the cervix, so that the bleeding is coming from the uterine cavity. So that
Yes,
is
ma'am.
So, ma'am, a thorough
adenomyosis is
speculum and per vaginal examination
Madam,
to
we
check for
state
the
that
mobility.
from the clinical point, I just want to confirm because globular uterus in the clinical
globular.
examination, ultrasonography also shows like that. So what are the things, features we will see in ultrasonography to either find out because most of us, we do ultrasonography. So what are the findings in favor of in ultrasonography for a adenomyotic uterus?
The myometrial zone, myometrial
More
zone
so the
is
Only one,
posterior
madam.
myometrium is more hypertrophied.
zone.
Yes. Only one, ma'am. Yeah. Dr.
Fibroid
Sasikala.
is irregular. Fibroid is irregular, and this is more globular adenomyosis. In the ultrasound, we find this finding, and endometrial polyp is again it can be seen in
It
the
can be
ultrasound.
differentiated by doing a saline infusion sonography.
Yes, saline
And then
infusion. We can differentiate.
and we can
So
also
the
always do a MRI to rule out
for
all.
ultrasonography, we can see the globular enlargement of the uterus,
Enlarged.
heterogeneous
The hazy,
myometrial
Invasion of
cyst.
glands in the
Thickness.
there will be
myometrium.
the
Thickness.
junctional zone will not be very clear. It would be very diffuse.
Yes.
Could show hyperechoic islands in the myometrial.
Yes, madam. So for asymmetrical thickening of the uterine wall. So that is one of the
Uterus.
4 or 5 characteristic findings because these are the findings whenever we do ultrasonography and actually rightly see, it's most of the time it's visible, these findings are there. Now,
Fiznur, Girija has logged in. Girija, please pitch
yes,
in.
ma'am. Ma'am,
Please
you can
unmute.
take over. Girija, ma'am.
No, I think it's an interesting discussion going on. I'm listening. Officer, continue. No problem.
No, ma'am,
I'm
please.
here.
I want to have this, madam, because this I myself knew what is MUSA or morphological uterus sonographic assessment criteria for diagnosis adenomyosis. Because the last features, these are actually most of the times we have been able to do it or see. Over to you. Yeah.
Okay, so basically you can just move to the next picture. Today what has happened is when we are dealing with endometriosis and adenomyosis and we have to do for surgeries either for restoration of their functionality or fertility. Many times we need to take a good recourse, and now with the availability of very high resolution ultrasounds, there are these structured techniques which have been proposed. Like for adenomyosis, there is this MUSA classification, which is a morphological uterus sonographic assessment is the long form. And this was proposed in 2015. And now recently, it has been updated and sort of verified or validated, as we can see in 2022. And many times, just looking at the ecogenicity or looking at some small structural thing, we tend to diagnose this as adenomyosis. But if you look at the characteristic features, if we can go to the previous slide.
Yes, ma'am.
Yeah. So you will find that there are certain important features like the distances and the unilateral unequal thickness of the walls, then lakes inside the myometrium, fan-shaped structures around. So all these and the endomyometrial junction. They can be structural linked. Today, many sonologists are using these graphs. Even we can use them so that you mark it either to identify whether your therapy is working or to understand how much restoration can be done. Likewise, for endometriosis in 2023, it is proposed what is called as the IDA classification. Again, a sonographic evaluation of the pelvis, the uterus and the ovaries so that we can classify and then plan our treatments, because all of us, and I can see that all colleagues here are extremely experienced gynecologists. You have all seen that these patients become our long-time patients. They don't leave us. They keep on coming back to us. And rather than getting frustrated, fortunately, we have newer molecules coming up. We have to have a structured approach to them so that we are able to deliver the goods correctly. So we can move around next. Anybody has used this MUSA classification in their practice?
No, not yet.
I have been using for the last about 2 to 3 years, the IOTA, the MUSA, and the IDEA. And that definitely makes a difference, not only to help patients, counsel patients, but also to make them understand that there has been a structural change which can affect their fertility, because otherwise they keep on expecting a lot of things from their treatments. And
Yes.
likewise, we can also take a recourse of a MRI, especially when we are planning a surgery, because today there are quite a few surgical approaches which can be considered for adenomyosis. Anybody is doing any thermoablation for adenomyosis? Anybody? No. I think none of us are doing, but then there are a few patients who have undergone these surgeries, but they have come back with again a vengently increased uterus. So I think we have to take it with a pinch of salt. How do we do this? So now we have already discussed cases of fibroids and various other AUBs. How about a patient of adenomyosis? What will be your primary approach? Anybody in the panel?
LNG, IUS.
LNG, IUS can be sometimes problematic as well, because sometimes if it's a hyperperistaltic uterus, it may get rejected.
Yes.
But yes, it turns out to be a good. Anybody
start
else?
with something as simple as NSAIDs, ma'am. Initially, 3 cycles of NSAIDs gives very good results in adenomyotic patients. I mean, it gives us almost 3 cycles, and then they're symptom free for like maybe 7, 8, 9 months after that. Then again, when they come back, then we have the option of starting with hormones, either oral or then maybe LNG, IUS, or various hormones we have now.
Even
The
in
PMDA
the
also.
large uterus, the chances
NSAIDs
of
are very good.
expulsion are more. There is more risk of expulsion in the large uterus.
Correct.
Actually,
So basically,
symptomatically,
if you look at this wonderful algorithm, somebody can just go through this algorithm and guide us and discuss this part. Yes.
Begin NSAIDs if not already started.
Rajesh,
If
yes,
the patient,
you can.
yes.
So if the patient, you can start on NSAIDs if not already started. Is the patient a candidate for LNG IUS? If yes, treat with LNG IUS. And if the patient improves symptomatically, if it is yes, continue with LNG IUS. If no, is the patient a candidate for an alternative hormonal therapy? So we can consider other hormonal therapy and can try on any as per preferred and availability. If the patient improves, trial of an alternative hormone therapy. And if the patient improves, if yes, continue that hormone therapy. If no, then uterine sparing resection or other uterine sparing intervention can be done. So what is, ma'am, anyone can have on that, or Giriza ma'am can have the conservative surgery on that?
Anybody has done this triple T kind of resections for adenomyosis? See, I know they are very rare cases, but they do sometimes benefit by these kind of treatments, especially when they are very young and you are wanting to conserve their menstrual function. Fertility function is always going to be doubtful, and we are now, these can be valid reasons for a good surrogacy program. But this kind of triple surgeries can be done. Can anybody tell us which is the largest size of adenomyosis hysterectomy that you have done? Because as postgraduates, we were always taught that the adenomyotic uterus doesn't go beyond 12 to 14 weeks, max to 16 weeks, because there's so much of
16 weeks.
symptoms and pain. But has anybody removed a very large one?
No, ma'am. Not bigger.
The
That's
maximum size I have removed is a 26-week size.
22.
Yes. And she had a hemoglobin of 2. She had undergone this kind of resection twice. And she was very keen of wanting to have a baby. She had become 42 now. I said, no way am I allowing you to keep that uterus inside. And she insisted that her cervix has to be kept behind. Her ovaries have to be kept behind. And one ovary was so badly degenerated and stuck because of endometriotic disease attached to the adenomyosis that I had to I did an open surgery. I called the husband inside the operation theater and I said, see, this is the situation. This ovary has to go. We are not going to keep it. So, sometimes they are really, and I feel with newer surgeries and newer imaging, we also feel, can we give them a chance and can we give them any possibilities? But we have to be sure that sometimes we may tend to take things too far, which should not happen.
There is a difference between the educated and the uneducated patients, ma'am. Because whenever we talk to the educated patient, they have a tendency towards conserving the uterus. But in our country, our part of the country, where the patients are illiterate,
they want to take it
tell
out.
them you have a fibroid and it is not to be removed. They'll never listen to you. They'll go to somebody else and get it removed.
And then they become.
And even if they listen to you and if they continue with the same fibroid, they'll have hypertension. They will have a diabetes because they are all the time thinking of gathan. They call it as gathan.
Rasoli.
Rajesh is saying something.
Madam, I have a question. We know about conserving the uterus, but what was this conserving cervix?
I have 2 patients who have insisted on conserving their cervix because they wanted to they go on the AI and they go on this Google and everything now, and they know that the cervix is important for orgasm. The G, they don't know. Poor things probably don't know where their G point is, but they feel that it is at the cervix. They want the vagina to be properly suspended. So they want the cervix to be kept behind.
Ma'am, we will go to the last 2 cases. We'll have another 5 to 7 minutes quickly.
Yes.
Sorry to interrupt.
I think the time is up.
Time is up. Yes, ma'am.
Time is up. Now then, I just want to make a comment on the previous discussion which was happening in a minute.
Yes, ma'am.
Like we were talking about doing the endometrial sampling, if you remember. And in that endometrial sampling, there was a discussion going on. Now, in the current guideline, doesn't believe in any thickness-based thing, because I'll tell you a recent example. In April 2026, an AUB patient of 42 years with no red flags had a 4 mm endometrial thickness on day 6 of her menstrual cycle. And we gave her an oral contraceptive pill for a cycle. After that, she did not take anything. May went by. In June, she presented with heavy bleeding. And I said, let's do your endometrial biopsy. We'll do a pipple biopsy in the OPD. And it turned out to be adenocarcinoma. So, we have to be now guarded. I have recently, just 6 months back, and this I always tell with a lot of sadness, a 26 years old, unmanaged, untreated, polycystic ovarian, hypothyroid, and obese patient. I have done a hysterectomy for moderately differentiated adenocarcinoma. So endometrial cancer has come to us with a vengeance, and we have to do everything under the sky to try and evaluate And sometimes, therefore, I'm a little scared in sometimes just putting a Mirena without doing an endometrial, sampling. We all know that the people sampling has its own limitation, and the best standard of approach is going to be a hysteroscopic evaluation. But at least something is done. Maybe this is not the right thing to say, but at least we are saved in case it turns out to be cancer. Medico-legally, we are happy that we have done some endometrial sampling.
May I add just 1 minute, madam?
Thank you.
Yes, Sonal,
Like
please.
we are doing using the endo sampler to get the biopsy, because that negative pressure, and because of that vacuum, those cells which are really fragile, who are more prone for coming out positive for malignancy, they are evacuated, and then we do LNG-IUS. In all my LNG-IUS, I do a sample with endo sampler. Because of that vacuum created, it gives better results. Just
yes.
Yeah.
Thank you so much. Meera ma'am, to you for your comments, because ma'am was not able.
I was
Yes.
listening. I was listening everybody.
Okay.
We have talked big things everywhere. But what I wanted to tell you, sometimes a patient like this came to me in 46 years old. One of my colleague's wife, and she was bleeding. It was 15th of August, so most of us were going for the attendance there. So by that time, I kept her for investigations and keep the OT ready because she was profusely bleeding. But as a routine, we have done RBCs, UC, ABC count, everything was done. And will you like to know that we stand up with the hands up because it came out to be acute lymphoid leukemia. She was bleeding profusely and everything was ready. OT was ready. We were just running because it was our friend's wife and whole of the staff was all the residents, registrars, and they were left, right. But as soon as the report came, it came out to be acute lymphoid leukemia. So what I want to tell that sometimes we go for very big things. There will be polyps there, a fibroid there. She has had 3 children. She has had a small fibroid which was hanging through for such a long time. She was perimenopausal and blood and everything was ready. But by the time we received a simple report, just changed our mind and line of action. So what I suggest that we must not forget the basic things when we are analyzing our patients. We know all big things, all big things here and there, but basic things should not be avoided, as was told earlier also. Basic investigation, basic examination. Maybe we have got an MRI on one hand and ultrasound, Doppler, everything, but PV may add something which is very important. So basic
Thank
things
you.
should not be
Thank you
forgotten.
all. Thank you so much.
Thank you
Our
very much.
audience is now restless for the post-test link. So please, if there are any queries, Hafizur, please answer in the chat box. And
Yes,
thank you, Meera
I'll do.
madam, for staying till the end and to give your expert comments. So the technical team, please post the test link.
Yes, ma'am.
Audience, please pay attention to your chat box. We are posting the test link and
Thank
she will
you
also
all.
share the QR code. Yeah. Yeah, it's
Thank you,
posted.
Girija. In spite of your emergency, you came and
Thank you
joined
so
for
much.
the.
Sorry, but I think Hafizul did a very good job. Congratulations.
Thank you, ma'am.
Thank you, everybody.
It was nice
Fantastic panel to
discussion.
wrap up the 3 days of excellent academics.
I think all are waiting for the link now.
Yeah,
And,
we
Yeah, the
shared.
link is posted in the chat box and the QR code is also there on screen.
Okay, congratulations, Lakshmi, and all the
Thank you.
conveners.
I'm really
Shobha
happy.
Gudi, Deepa Gupta,
Nilima said
Shashibala,
there are 12,
and
Pratik said 1250 registrations for the AUB course. Good.
yeah, Meeta
And even
Gupta.
now there are 335 people who are logged in who are attempting the post test, which means we will have at least 300 people who will receive the credit point certificate.
So hats off to the ICOG leadership.
Hats off to
Great.
you, past
Absolutely.
chairperson. Well done.
आपने तो शुरू किया है. Thanks to
This
Dr.
is,
Mandakini Meg,
yes,
madam, actually.
she started. But it's really going great, ICOG certificate courses. Yeah. Technical team, please repeatedly keep on posting the link.
So for those of you who are not fellows of the college yet, 15th of July is the last date to apply for the ICOG fellowship. Our office staff is always there to help you with the applications. And we look forward to many of you receiving the ICOG fellowship at the convocation in Bangalore, 22nd of August, Saturday afternoon post-lunch session. The ICOG annual conference, the 11th ICOG annual conference, will be held in Bangalore, 21st to 23rd of August. All of you are cordially invited. Please do come in large numbers. And we would look forward to connecting with each and every single one of you who has been part of the audience on a very personal basis, on a one-to-one basis. Thanks to all our GCMs who have attended throughout the 3 days in various different capacities. And many of you who have not been faculty for this particular course have still attended. So thank you very much for your loyal and good support. Dr. Sheila Mane, ma'am, do you want to speak about the past registry?
Yeah, I think we have been informing everybody that we have started a registry on placenta accreta spectrum, and please spread this message. You will get, I think we will try to share again this registry, Dr. Pratik, when we share the certificate, so that we will reach out to more and more people. Yeah, so that we will do. And mainly the cases are handled by either the medical college or the corporate hospitals and the multi-speciality hospital. And I must share with you that already we have 27 cases uploaded within a short duration. It is just 2 to 3 weeks.
Also, we are coming up with studies on PCOS, endometriosis. I've just spoken to Damodar yesterday regarding the format and the sequence of events, how the endometriosis study is to be conducted. So many more academic activities on the ICOG banner coming forth. Please stay tuned and we will be in touch with you regularly. Many people have already said that they have done the link. 20 questions are done already, but we'll wait for the remaining 10 minutes. Hafizur, nice panel. Thank you for being here with us. Always appreciate your hard work and efforts. Hafizur and I were co-ICOG Governing Council members. Usually whenever there is a convocation, you can see him and me running around trying to get things organized.
Thank you
I
so
remember.
much.
The questions were fantastic. Actually brought out the best cases.
Thank you, ma'am.
Hafizur is also part of our ICOG postgraduate clinic, which is run every Sunday at 11:30 in the morning.
Yeah.
Second Sunday, yes. Thank you for all your contributions to ICOG. Yeah. We look forward to seeing you and your contributions in future as well.
What is we say, sir, the PG students are so much, it has been increasing from the previous editions, because now I get from the different college, the students would like to present, and there are many faculties, those who are interested to become faculties. And that's really great. Correct. The program which is going from 5 years and the still to be attached to the program.
No, I think it's very important for people from the Northeast, specifically postgraduate teachers and eminent faculty like you from inaccessible areas, to come forward to connect with mainstream ICOG, connect with a lot of postgraduate teachers and faculty from all over the country, because we have very few representatives from the Northeastern region, both in FOGSI as well as ICOG. So I'm very happy to see your progress as well.
Yeah. And we see, sir, there has been some great teachers in many colleges, in peripheral colleges, and they actually really does wonderful in the ICOG PG clinic academic activity, and they actually don't get the platform. That's what I see.
Yes.
I think Silamane ma'am, you also will agree. There are many faculties who have done really good in the national platform as well. And I think ICOG, as being in the ICOG, should always try to promote those faculties, those who are doing such good work teaching the students, but they are not getting the opportunity to see in the
Correct. Similarly, from Jammu, we have Dr. Meeta Gupta, Dr. Arun Arora. Both of them are excellent teachers. We are very happy to see Meeta as one of the governing council members. We look forward to your active participation in future activities as well. And Dr. Arun, hopefully, he will get elected as a GCM in the next tenure. We are always happy to promote and encourage people into the mainstream of both FOGSI and ICOG, especially those who don't get so many opportunities.
Thank you, sir. Hi, Meeta. Coming to Bangalore.
Yes, ma'am.
Meeta has to come. She's a GCM. If she doesn't
Yes,
come,
ma'am.
it will
Yes,
be a
sir.
black mark.
No, sir. I'll be coming, sir.
Attendance will be maintained like that.
What about Hafizur?
I am coming, ma'am. I have already confirmed in the invitation.
So there's a question, in case you don't receive the certificate, you can get in touch with me or you can get in touch with our ICOG office staff. Nilima and Poonam both are always happy to assist you with any queries. Also for your fellowship applications, if you need any clarifications, if you need any doubts to be clarified, please get in touch with either me or with the ICOG office staff. We are happy to assist. 15th of July is the last date, and I want to see maximum number of FICOGs, these two convocations, both at Bangalore as well as Surat. So for those of you who have not scored 50% on all 3 days, each of the 3 days, you will receive a certificate of attendance. It will be without credit points, provided you have attended for at least 2 hours on each of the 3 days. And that is an automated process. The system actually looks for your login and logout times. Based on that, the certificate of attendance is generated. Lakshmi ma'am, any closing remarks? Gratitude, thanksgiving?
Yes. I thought it will disturb the participants from giving exam.
That's
That's
okay. They
why I
can
was
lower their
keeping
volume. They
yeah,
can lower their volume.
they can mute from their end. No, I am really thankful from bottom of my heart, starting from FOGSI President, Dr. Bhaskar, ICOG Chair, Dr. Sheila, you as ICOG Secretary, and all the ICOG office bearers for giving me this opportunity to be convener for this prestigious FOGSI ICOG 3-day certificate course on abnormal uterine bleeding. And my sincere thanks to each and every faculty. I know there are 75 faculties. We had 25 faculties per day. So please pardon me. I just cannot take each and every name, but I am really thankful to you, all of you, for sparing your precious time, sharing your wisdom, sharing your experiences with all our delegates who had logged in. I'm sure they all are carrying practical take-home messages which they can implement in their day-to-day practice. Because as Dr. Sheila Mane and Dr. Pratik already said, AUB is the commonest indication for which we are having gynecological consultations. And if this course can bring any change in your practice, I am sure this course will be a great hit and it will be a great service to our patients as well, because we have to keep ourselves updated. And all the speakers have focused on the latest guidelines and all the latest changes which has come in the field of diagnosis and management of abnormal uterine bleeding. So thank you for being here and for joining in such large numbers and for giving the exam. And Pratik, the questions were very, very simple. I am sure nobody will score less than 50%. Rather, I am sure everybody will score 100%, provided they were attentive to all the talks and the panel. Thank you. Thank you, Dr. Sheila and Pratik, for having me and being the convener of this course.
Always a pleasure and a privilege to have Dr. Lakshmi with us. I was a governing council member incidentally. So even now she checks her audio video. She asks me, Pratik, audio video बरोबर है कि नहीं?
आदत हो गई ना, क्या करूं?
Thank you, Dr. Lakshmi. Thank you, Dr. Pratik, Dr. Sheila. Thank you so much for the great opportunity. Obliged.
Thank you, Dr. Tarini ma'am. Always lovely to have you with us. Look forward to seeing you in Bangalore. I hope you booked your flight tickets.
I have
Oh,
booked,
you
Pratik.
reminded
I
me.
have
I
booked.
will book. I'll book.
I have booked. I am
I
in
Kar lo
touch with
jaldi.
Dr. Sheila.
I
I
Yes.
have not
request
booked, but I
everyone,
will book.
शीला माने मैम, आपका 7H का पूरी तैयारी हो गई है with MP societies on 2nd July. So please,
Okay.
please don't go away, any one of you. All of you are invited to MP.
Not
And I
going
think our
anywhere.
other governing council member, Dr. Kanchan Prasad, is doing another 7H CME with the remaining UP societies. I think she'll get in touch with
Okay.
you for the dates, ma'am.
डॉक्टर प्रतीक, हम लोग का मुजफ्फरनगर का कुछ करना था.
हाँ जी, करेंगे ना जरूर. आप हुक्म
Okay.
कीजिए, हम हाजिर हो जाएंगे.
I
Nah,
think
thank you so much.
seventh Sita is doing with Bengal.
Okay, ma'am.
Madam, you had given us the date of 2nd. So I do.
Yeah. For you, okay. 7th Sita is doing.
Oh. So looking forward to all of you there. Seeing you all there.
Probably on Ma'am, 28th August, 1-day workshop, probably in Jammu. Critical care we'll be doing, ma'am.
That is in October, no?
Sounds good.
No. ICOG activity you are doing.
Yes, ma'am. ICOG activity,
Yeah,
ma'am.
yeah.
In 28th August, most on dedicated on e-fast and maternal collapse, ma'am.
Very good. Please go ahead.
Thank you, ma'am.
You can send a letter to ICOG and you
Send a
can
formal
consider it
email
as the
so that it's
ICOG
there in the
CME.
system.
Yes, sir, we'll do it.
Because Nilima and Poonam will record all the dates with the societies, and that is part of my secretary's report at Bangalore.
Madam,
we can show that as
IC
part of the
committee,
system.
Aruna Suman wants to do with ICOG. One webinar.
No,
I
ask
think
her to
there
call
is no
me.
committee which does not want to do one with ICOG.
Yes, that's
We have had so
She
many
asked me,
requests.
how do you do it? So I said, you have to ask the Honkos of the ICOG. They will give you permission. So everybody wants
Pratik,
to do
Dr.
it.
Sandhya Chassatia is from Surat and she is informing all the attendees that the early bird registration for AICOG Surat is 30th June. So
Yes,
please
ma'am.
register before 30th if you want to have the benefits of early bird registration.
I'm regularly getting messages from Dr. Nimish Shelat and I'm forwarding
Yes.
them to my groups as well. In
Yes,
fact, I
she is.
recorded a video at Delhi encouraging people for the early bird registration. I think they had sent it as part of the promos.
Yes. Because there will be ICOG convocation, ICOG session, CL Jhaveri symposium.
CL
So
Jhaveri
we
symposium.
really wish you all to be there for AICOG Surat.
Madam, one more
We have
query.
20 seconds to go.
One more query, sir. Some few of 5-6 people are coming from Gwalior, but 1 or 2 are saying if we can't make it to Bangalore, can we get the convocation, attend the convocation in Surat?
Yeah, just let them send a formal email to the office and we will record their preference.
And ask.
Great.
As I said yesterday, we are preparing the pamphlet, just like the RCOG has the pamphlet with the list
let
of
me
the
know
honorary
their names.
fellows.
Yes,
So that if we can involve them as faculty somewhere.
Yes, ma'am. Yes.
Okay.
I'll give you the list who all are coming from Gwalior. Quite a lot.
Okay.
Yes.
So now I think you all are waiting for the answers. Please display the answers. So the first question was AUB in adolescents is often due to immaturity of. The answer is B, that is hypothalamic pituitary ovarian axis. Second was most common cause of AUB in reproductive age. It is ovulatory dysfunction. So answer is B. Question 3 was first investigation in postmenopausal bleeding. It is transvaginal ultrasound. So the answer is C. Fourth was endometrial thickness cutoff in postmenopausal bleeding for biopsy. The answer is B, that is more than 4 millimeter. Most common coagulopathy causing AUB is, answer is B, von Willebrand disease. Obesity increases risk of, answer is B, that is endometrial hyperplasia. Diabetes is associated with increased risk of, endometrial carcinoma. So the answer is B. 8th question was tamoxifen therapy is associated with, answer is B, that is endometrial hyperplasia or endometrial cancer. Chronic anovulation leads to estrogen excess, so the answer is B. AUB with obesity plus PCOS suggests risk of, the answer is endometrial hyperplasia, so it is B. Most common type of endometrial cancer, answer is B, that is endometrioid cancer. Major risk factor for endometrial cancer is unopposed estrogen, so the answer is B. Endometrial hyperplasia without atypia, the risk of malignancy is less than 5%, so the answer is A. Hyperplasia with atypia, the risk of malignancy is 30 to 40%, so here the answer is C. Gold standard for diagnosis of endometrial cancer is, of course, histopathology, so the answer is C. First line treatment for hyperplasia without atypia, the answer is B, that is progesterone therapy. Definitive management of atypical hyperplasia in patients who have completed family, the answer is hysterectomy, that is C. Postmenopausal bleeding where ET is more than 4 millimeter, your next step should be endometrial biopsy, so the answer is B. Most common presenting symptom of endometrial cancer is postmenopausal bleeding. So the answer is B. And the last question was Lynch syndrome increases risk of, answer is B, that is endometrial cancer. So I'm sure you all must have scored the 100% and you will get your certificate within 1 month from ICOG office.
Thank you, everybody. Goodbye. God bless. End of the third day's proceedings. Parting is sweet sorrow, as Shakespeare said, and we look forward to seeing many of you in person at the ICOG annual conference. Goodbye.
Thank
God bless
you.
and back.
Thank you.
Bye-bye.
Bye.
Bye,
Good
bye,
night.
Dr.
Bye.
Lakshmi.
Bye.
Bye.